thank you once again for this wonderful demonstration, and we'll have you back in an hour or so once Dr. Fishman finishes his next two lectures, right? So I'll see you once again. Bye. So after that, we will be moving to Dr. Elliot Fishman once again, and he is there with us online. So sir, you could please continue with, I guess, with the liver series now.
Okay, thanks very much. And I didn't realize, I'm not very good on time, but I didn't realize that it's late Saturday night for you guys. So I appreciate everyone being around. So this is on liver masses, key differential pathways. And obviously, if you think about it for a second, one of the real big applications of CT for literally the past 40 plus years has been looking at the liver. And a lot of the effort went on detecting liver disease, the presence of small lesions. There was a lot written about different protocols way back when scanners weren't quite as fast, but as now the ability to scan in a couple seconds really has changed how we really define the protocols. But I think a lot then focuses on, can you be very specific into what the etiology of a lesion is? And so that's what I'm going to look at today. I'm going to focus more on some of the benign lesions and then get a little bit into malignancy. But I think at the end of the day, one thing we recognize in liver imaging, particularly when you deal with oncology patients, is simply to say a patient has a small lesion. This is not really that helpful, because if you say a patient has a lesion, does that mean the patient has metastasis, or is it something else? So simply lesion detection is not in and of itself a panacea. It's really how good are you at specifically determining what a lesion is. So in terms of protocols, we look at the liver with doing dual phase imaging, basically arterial in about 30 seconds, venous in the 60 to 70 second range. We rarely do late phase imaging, occasionally, but it's rare. And we do not do non-contrast scans. And so what I'll speak about is, again, focusing on benign lesions, a little bit on malignancy. Obviously, there are many more talks on parenchymal disease and infectious disease, but we won't have time for that today, obviously. If you look at benign tumors, when I think about them, there's really four things I think about: cysts, hemangiomas, FNH, and hepatic adenomas. And I think they're important in this sense, obviously, except for hepatic adenoma, which you can consider in some sense pre-malignant. All of these lesions tend to have signatures that can allow you to diagnose them very specifically in most cases. And that becomes very, very important. People have talked about different strategies. The importance, of course, of being able to be specific is that you don't keep adding on additional studies. If you simply read your scans as the patient has a lesion, here's a differential diagnosis, then you end up with either an anxious patient, an anxious referring physician, or more and more studies. So if you think about hepatic lesions, I like to think about cystic lesions and put them into the category of developmental, inflammatory, neoplastic, and trauma-related. When you think about hepatic cysts, they're very common. It's kind of like renal cysts, 10% of patients, invariably easy to diagnose. Most of them are under a sonometer. In fact, they get really difficult to diagnose when they're a couple millimeters, where you can't really tell much about a lesion, perhaps. They can be single or they can be multiple. When you talk about liver cysts, what you typically are saying, there's a lesion, it's water density, it's well-defined. There's no enhancing walls. Almost never does the wall calcify. Usually calcifications relate to prior trauma or to infection. Well-defined, single or multiple. They don't typically cause perfusion changes in the liver. Now, I will admit that if liver cysts get large enough, particularly if they're centrally located, they can compress the IVC and they can cause perfusion changes in the liver. And they can, in fact, compress the IVC and even cause lower extremity edema. So although cysts are always hepatic benign cysts are always not going to cause problems. I mean, they're always benign. They can cause problems. Okay, so real simple there. Hepatic cysts can be large. When they get large, the mass effect can stretch the liver capsule. Patients can be symptomatic. So this patient, in fact, presented with a right upper quadrant pain. When you think about cystic lesions, you also at least in your mind, go through what else could this be. And I'll show you some examples. Obviously, if a patient had trauma, you would think of biloma. If the patient had surgery, particularly laparoscopic surgery, gallbladder, pancreas, liver, you think about biloma. If lesions are cystic and they're within the liver, you'll say a cyst, but you'll also say, what about a cystic metastasis? And I'll show you some examples. But the things we all look at, we look at density, we look at the wall. Is there a wall present? Is there wall thickening? Then I change my diagnosis. If there's enhancement, I change my diagnosis. Thin septations, like in this case, do occur. So cysts can have septations, very much like cysts in the kidney. As long as the septations are thin and there's just one or two septations, I really don't worry. Obviously, cystic lesions with multiple septations, you can think of things like hydatid disease. We have daughter cysts, but that really is a very specific appearance. Hepatic cysts typically, even when they're relatively large, like this case, do not distort the vessels, though again, anything large enough can distort vessels. Here it is on the MIP imaging. You can see around the edge of larger cysts what almost looks for a second like, maybe is this some enhancement here? Is there something going on with the border of this lesion? But what you have to remember, of course, is when cysts are large enough, they compress the hepatic parenchyma. When you compress the hepatic parenchyma, you can stretch the hepatic artery. You can have perfusion changes within the normal liver adjacent to the cyst, or simply stretch the hepatic artery out, which is what you can see here. And the subtle enhancement is the hepatic artery within the compressed parenchyma. Again, not difficult to make the right diagnosis. We can have multiple cysts. The classic example for multiple cysts is polycystic kidney disease and polycystic liver disease, like this example. Half the patients with polycystic liver disease also have polycystic kidney disease, but you don't necessarily have polycystic disease just because you have polycystic liver disease. And just a nice example, just the range of size of cysts and the septations present. I mentioned how if a cyst is large enough, it can cause perfusion changes. This cyst was very large. It was centrally located, compressing the IVC. You can see perfusion changes in the liver. The patient also had lower extremity edema. Eventually, the cyst had to be drained and marsupialized. In terms of differential, you can see little clips here. This patient had prior surgery. This looks like a cyst, but based on the history, this is a biloma. And bilomas can look identical to simple cysts of the liver. But again, the surgical clips, the history makes life very easy for your diagnosis. I mentioned cystic metastasis. Certain tumors can give mets to the liver that are cystic. Ovary and GIST tumor are two of them that come to mind very quickly. What you can see in this case, obviously there are multiple lesions beyond this large cystic lesion that are enhancing, and so you have no problem calling this metastasis. But you recognize this lesion has a thicker wall. There's subtle enhancement within the density of the cystic component. And when you do things like volume rendering, you really can accentuate the cyst wall as well as the contents of the cyst, which appear to have some enhancement. Simple cysts do not enhance on early phase or late phase or delayed phase. There's never enhancement. When you start seeing enhancement in a cystic lesion, you have to worry. It's surely not a simple cyst, and it could be a cystic metastasis. And here's just a nice example. Or in this case, this patient has spindle cell sarcoma. This is a little bit easier, but you can see the main component of this lesion is that it's cystic, but you see the irregularity of the wall. There's some calcification. When you look at the volume rendered images, you very nicely see some of the neovascularity in the cyst wall. With simple cysts, you can see splaying of the vessel. I showed you that a few moments ago, but you're never going to see this type of vascularity. Again, I like looking with sliding MIPS through the liver routinely. It gives me a better feel of the vessels, and it helps me pick up any type of vascular irregularity. And here's that same patient as we go to venous phase imaging. The wall is enhancing, it's thicker, it's irregular. What about this case? At first glance, it looks like a cyst, but then you look more carefully, and it looks like some thickening along the wall. And then we look a little bit more carefully, and you can see there's some enhancement of the wall. And inferiorly, I'm sorry, machine's jumping. And inferiorly, there's irregularity. That's not a simple cyst. And what that was a cystic metastasis from a patient with a GIST tumor. So again, looking and being very strict, looking at borders, enhancement, the wall, the interface between the cystic lesion and the normal liver all becomes very important trying to reach the right diagnosis. And here's just another example of a cystic metastasis to the liver. So not very difficult. Again, the wall thickening, the areas of enhancement centrally. Again, very important not to make a mistake on. Now, in terms of things that also can be cystic, liver abscesses are one of them. Depending, amoebic abscess, classically right lobe of the liver. The difference between a simple cyst and an abscess is when you start doing some narrow windowing, you do see perfusion changes within typical abscesses in the liver. So you can see all of the perfusion changes in the right lobe of the liver here. You also see the irregularity of the cystic lesion, and that was a liver abscess, that was E. coli. Patients post-op, this was post-op Whipple's. You always worry post-op. This is about 2 months post-op. This was actually concerning for a MET. It was just a routine follow-up. But this has that donut appearance, which is very good for abscesses. So again, it's cystic, but there's an enhancing wall to it. And so you have a rim around it. So the one thing this is not is a simple cyst. In the right case, this could be cystic metastasis. In this patient, it was an abscess. Obviously, cystic lesions with air bubbles, you can occasionally get fistulas, but most commonly it's in a case like this with multiple air bubbles, air fluid level, and it's an abscess in a post-op patient, but that's not very difficult. I have seen patients who've had cysts in the liver, which secondarily get infected in patients with ascending cholangitis. So that can indeed happen. When I look at cystic lesions and I think about cystic lesions that are metastatic, I showed you a couple of metastases, the spindle cell, I showed you the GIST tumor, but you also think about primary liver lesions like biliary cystadenomas and cystadenocarcinomas. It used to be felt that they were two separate entities. Now it's pretty much felt that all cystadenomas are pre-malignant, so they're kind of treated the same with resection. Also, things like hepatoma can be cystic, mainly cystic and necrotic in that scenario. And unusual things like mesenchymal hamartomas and inflammatory myoblastic tumors, but those are exceedingly rare. We also talk about multilocular cystic liver lesions. Like I showed you an example of an abscess before, hematomas, biliomas, and cystic disease. Now with biliary cystadenoma, it's usually going to be females. Again, cystadenomas can become cystadenocarcinomas, so they're treated the same. The typical appearance is a large cystic lesion with multiple septations. The enhancement of the septations or the wall commonly occurs. And you can see a nice example here of a lobulated lesions, multiple cystic component and multiple septations. I will say the biggest challenge to me now in the US, we don't have many cases of Hydatid disease, but in places in the world with Hydatid disease, and India has a higher incidence than the US, let's say, a patient younger, particularly a patient who has fever, you could think about that possibility because it has almost that same appearance of multiple septations. Remember, in the Hydatid disease, you're talking about daughter cysts. Here's a more classic example, large cystic lesion of the liver, but again, multiple septations, multiple cysts, biliary cystadenoma is a diagnosis. This patient will get a partial hepatectomy. And here it is on the coronal view. So again, septations, cystic components, multiple cystic components are really classic for biliary cystadenoma. Now, a challenge is not every biliary cystadenoma looks like that. Here's a cystic lesion in which you wonder, is it in the liver or adjacent to the liver? We kind of figured it was in the liver. When you look hard, there's some septations. There's a little bit of wall irregularity. So it wasn't just a simple hepatic cyst that was exophytic. We didn't know what it was. Patient wasn't patient wasn't febrile, so it wasn't going to be an abscess. Patient was female, it was the right age. So this was eventually resected, and this was a biliary cystadenoma. I show this case to show the difficulty that sometimes these cystadenomas are exophytic. In fact, this was initially looked at and felt to represent the gallbladder till you realize the gallbladder is sitting right here, and that can't be the gallbladder. But again, those septations always do worry me, and I'm not going to simply stop at that point. If you have any questions, ultrasound is good at looking at septations. MRI is also good, particularly looking at the lesion solid components. So MR with gadolinium can be very helpful, but you can see this is a tricky case. Again, I showed this in conference. Someone said duplication of the gallbladder. Okay, duplication of the gallbladder does occur, but that's not the diagnosis in this patient. I do find that as you go to 3D imaging with volume type displays, you can accentuate things like septations more. I think when you have a single thin axial slice, it's a bit tricky at times. Coronals are a bit easier, but the volume display is even better. Okay, another lesion, hemangiomas. Hemangiomas are very common. About 90% of hemangiomas are classic, which means there's peripheral enhancement and there's a peripheral to central filling in. In the old days, I remember when I first started in CT, we'd follow these cases for up to a half an hour. People would not diagnose hemangioma unless the lesion became isodense. Well, we all know, first of all, that many lesions, even hepatomas, can become isodense if you wait long enough. But also, you don't need to see a lesion become isodense to call it a hemangioma. The fact is, the best diagnosis for hemangioma is on the earliest 30 to 60-second images when you have that puddling around the lesion. So big mass, there's some puddling. There it is again. When lesions are over 5 cm like this one, they're called giant hemangiomas. Interestingly, the giant hemangiomas tend to have a better frequency of peripheral puddling, making it easier to diagnose. Often it's a small hemangiomas under 2 cm, often under 1 cm, that don't have that peripheral enhancement that make it just a touch more challenging. When you start looking at these images on the coronal view, you see the puddling around the edge. I will say that using MIP imaging gives you a better feel of the puddling. And sometimes if you're not certain, sometimes the puddling is a little bit later, but you only have earlier phase imaging, that MIP can be very helpful. As you go from that 30-second to 60-second, you can see here the puddling is increasing, very classic. You know, we talk about rim enhancement with metastasis, rim enhancement in primary malignancies in the liver. But this is not rim enhancement. This is that puddling. You can see that cloud appearance, very classic for hemangioma. There it is again and again. The MIP really gives you that feel of the puddling. With hemangiomas, particularly when they're large, at times can see feeding vessels going into them, but more typically it's to the edge of the lesion. At times, the feeding vessels can be a bit large when you have very vascular hemangiomas, but they're never irregular like you see with malignancy. And as you go and follow the lesion downward, the lesion fills in. Now, with larger lesions, fill-in time can really take up to 30 minutes, and we don't follow the patients. But from this appearance, I know we're dealing with a hemangioma, and I don't need to do anything any further than this. And again, here's just some nice images. Now, it used to be said that hemangiomas had to fill in their entirety, but when you start seeing particularly larger lesions, you realize that often there's a central scar in larger hemangiomas. We typically describe central scars initially with focal nodular hyperplasia, but you can see central scars in tumors even, but on benign lesions like hemangiomas, central scars, as in this case, are not going to be uncommon. Here's another patient, giant hemangioma, all of 13.3 centimeters. There's additional hemangiomas next to them. Hemangiomas are often multiple. Again, you see very nicely as we go from 30 to 60 seconds, the very rapid peripheral puddling, and the lesion begins to fill in over time. And here it is on the volume display. Again, the puddling, that kind of whiskering around the lesion. So you should not be confusing this with tumors, be it a hepatoma or angiosarcoma or anything else. And again, the puddling on the MIP image on the right is very classic. Another example, again, very nice peripheral enhancement and puddling, classic for hemangioma, again shown on the MIP imaging. And as you can see, as we go from 30 to 60 seconds, the lesion continues to fill in from that peripheral to central pattern. And here it is a little bit later. So again, just a classic way of thinking about hemangiomas. Now, hemangiomas most commonly are less than 5 cm. Here's just about a 3 cm hemangioma here with puddling. There's a 1 cm hemangioma here. When hemangiomas are small, that means under 1 centimeter, the lesion may fill in its entirety, kind of like a starry night appearance. You often see a tiny feeding vessel like this case, but with small hemangiomas, they may just fill in like a flash bulb. So it's important to remember that not every hemangioma is going to have peripheral enhancement and then central filling in. I think when they're small, it can be more of a challenge to you, especially if you're dealing with a patient, say, oh, this patient has a malignancy, maybe a neuroendocrine tumor. How do I know that's a hemangioma flash filling versus a metastatic neuroendocrine tumor? It can be a bit tricky at times, but usually the appearance of the feeding vessel and the appearance of the lesion itself make it a bit, not as difficult as it makes it sound. Occasionally, you may need to do another study, and MR usually works well if you're not certain. And again, here's that same lesion with the peripheral puddling. And there's the peripheral puddling, the filling in, the feeding vessel, all classic findings. In terms of feeding vessels to lesions, I mentioned this a moment ago, but I will re-mention it, that I think it's really the MIP imaging that really gives you a better feel of the feeding vessels. When you look at things only as axials or even coronals and sagittals, it's hard to follow a specific vessel for more than a couple centimeters. It's much easier when you have it as a MIP. And again, here's that case filling in from peripheral to central, that classic appearance for a hemangioma. Now, it's interesting, every case I showed you, whether they were small or large, was intrahepatic. Almost all hemangiomas are intrahepatic, but there's a few cases that may not be. This patient was referred to Hopkins for a GIST tumor. Remember, I showed you GIST tumors being exophytic, and it looks all the world like a GIST tumor, except I noticed it had peripheral enhancement. Now, I have to admit, I read this case, the requisition said GIST tumor. The surgeon was a GI surgeon. So I described it and I said, it's kind of unusual to have this puddling appearance. Well, this was operated on and it came back hemangioma. I called pathology. I thought they made a mistake and they told me I made the mistake. What happened here is there's the left lobe of the liver and there's a little piece of liver. And this is essentially a polypoid exophytic hemangioma. Hemangiomas can arise off the edge of the liver and push on the stomach and look for all the world like a GIST tumor. What I should have recognized was GIST tumors don't enhance like that. This is the enhancement of hemangioma. Here's another example. Same thing, was originally felt to be a GIST tumor, but there's that puddling, very nicely shown. So every once in a while, hemangiomas can be exophytic and they can be challenging. I've seen them biopsied and the biopsy comes back a vascular lesion. Then all of a sudden, the diagnosis becomes angiosarcoma. So you want to be very careful. I've seen at least 2 or 3 quote unquote angiosarcomas of the liver that were actually hemangiomas. And here it is very nicely on the volume rendering and on the cinematic rendering, just showing you that lesion very nicely. Now, with hemangiomas, you can see perfusion changes. When they're very vascular, you can see perfusion changes. I'm always a little bit concerned when I see perfusion changes because to me, perfusion changes are something that I always think about with malignancy, particularly Mets, but any type of malignancy. Here you can see the lesion's very vascular and then it fills in and the perfusion changes go away. But I look very carefully at those lesions because I'm always concerned when I see perfusion changes that I could be in the realm of malignancy. And here's just some examples. Same case, just showing you the perfusion changes accentuated on the cinematic rendering. And again, there's the lesion, hemangioma, and those are the perfusion changes. I think it's a little tricky. As I mentioned, when lesions are very small, this was a hemangioma. It almost looks like a met, and it can be very challenging. Feeding vessel may help, but small lesions where you just have like a rim enhancement like this ring, that's also a description with metastatic disease. So it can be a little bit tricky. Again, with Mets, more commonly you see perfusion changes. With hemangiomas, it's less common. Now, other lesions, what about this case? This case was a big vascular lesion. You can go through a differential, but in 30 seconds, it's gone. So what lesion is very vascular, but only as vascular as the IVC, not the aorta, is not in a cirrhotic liver, and then becomes isodense? And the answer to that is a focal nodular hyperplasia. Here's another example: vascular lesion, isodense, no peripheral enhancement. A bigger lesion, very vascular, but no neovascularity, no underlying cirrhosis, central scar, very classic, focal nodular hyperplasia. FNH is a benign lesion. I wrote an article, the first article I ever wrote was on FNH, and we wrote at that time that scarring centrally was classic for FNH. Obviously, it's classic for FNH, but it can be seen with multiple other lesions as well. FNH is a benign, leave-alone lesion. It does not bleed. There's no malignant potential. Most of the patients are asymptomatic, okay? Second most common benign solid liver mass after hemangioma, but a lot less frequent. The thing about FNH, the key is recognizing its enhancement pattern so you don't work the lesion up like it's a hepatoma. Classically non-contrast, iso or hypoattenuating, arterial vascular, hypervascular that is, looking like the IVC, but not as bright as the aorta, and then quickly becoming isodense. So here's another example, looking a little bit like the last case. FNH can also be multiple. That can be very helpful. Again, that central scar. You often will see a feeding vessel going to the central scar. So here's a good example. Central scar. Oops, there's the feeding vessel. Here it is on MIP. There's the feeding vessel, a little better seen. The lesion's hypervascular, homogeneous, only as bright as the IVC. And look how quickly the lesion becomes nearly isodense with the liver, though you still see its scar and a little bit of the vessel at the edge of the lesion. So here it is again, okay? The lesion is basically gone. So we know that lesions can become isodense, hemangiomas become isodense, hepatomas can become isodense, metastasis can be isodense, but FNH is the classic one, vascular, central scar, bright as the IVC, and then it disappears, okay? Just another example. And again, FNH can be challenging if it occurs in a patient with malignancy. How do you know it's not a MET? But again, it's looking at the enhancement pattern and looking how things become isodense, and the whole pattern works out very, very nicely. FNH, as I mentioned, can be multiple, so that's an important thing to think about. And again, from the pearls, that idea that it only becomes as bright as the IVC, not the aorta, and the fact that it's very bright, but only as, but it's also homogeneous. Now, most of them, as I showed you, were intrahepatic. They can be exophytic. This was a medical student actually presented a number of years ago with right lower quadrant pain, palpable mass. They thought it was appendicitis. We did a CT. It was this large vascular lesion, which was FNH. Here's a few more examples, multiple FNHs. Each of them behave the same, the feeding vessel, the central scar. And here's just one more example of a lesion that was FNH, that was exophytic. I think in this case, I knew there was a liver mass. This was biopsied as some type of sarcoma at first, just an unusual appearance. This was resected, and this was FNH. So FNHs can be pedunculated. This article says 9% of the cases, but I have to admit, in my experience, it's a lot less frequent. And again, if you say, well, are you sure I could distinguish a FNH from malignancy? Here's a lesion. Okay, what are you looking at? Vascular. Could this be FNH? This lesion is liver is cirrhotic. I don't call lesions in cirrhotic liver FNH. You see the vascularity goes to the edge, not into the lesion proper. This was a small hepatoma. Also on the washout, remember how it became isodense with FNH? Here you see the rim is enhancing and you see prominent enhancement in the peritumoral region. With FNH, when it becomes isodense, the liver is homogeneous. Here it's not homogeneous, and this was a hepatoma. So again, there is some overlap when you look at little features of the lesion, but when you look at the entire lesion and its spectrum over time, you can very much reach the right diagnosis. Now, when I mention FNH, I always mention hepatic adenoma. Hepatic adenomas are typically associated with oral contraceptives. The issue with hepatic adenomas, they're often considered pre-malignant. There's a lot of categorization now in pathology of hepatic adenomas, which ones are pre-malignant and which ones are not. One of the things about hepatic adenomas, they're classic for spontaneous bleed. A young female with spontaneous liver bleed has hepatic adenoma till proven otherwise. Other things that bleed include vascular malformations, obviously, hepatoma. Hepatic adenoma is the classic. It can be single or multiple. They do enhance and can look very much like a hepatoma. Often the helpful thing is that they're not in cirrhotic livers. So here's an example of a lesion enhancing. There's some peripheral vessels coming to the lesion. You could think about FNH, but it didn't have that homogeneous enhancement pattern. As you watch it across the delayed phase, it doesn't wash out. It's a little less bright, but you can see some rim enhancement. I would worry about a hepatoma in that case. Another patient, right upper quadrant pain, vascular lesion in the liver, some vessels to the lesion. Again, I'm thinking hepatic hepatoma, but there's no evidence of cirrhosis. But of course, you're going to have hepatoma without cirrhosis. You can see the lesion as we go to venous phase imaging, well-defined on cinematic. Another example, a lesion infiltrating the left lobe of the liver. Hepatic adenomas may be very subtle. They may have this increased vascularity. They can enlarge the liver, and they can be infiltrative. You can see them nicely when you do the MIP here. You can see the prominent vessels and stretching of vessels. And as you go from arterial to venous, they may become less defined. So hepatic adenomas can be challenging because they can be what I would say is infiltrative, and you surely would worry about something like hepatoma. You can see as you go to later phase at about 5 minutes out, the lesion's totally isodense. You see some textural changes, maybe some shape changes, but it's indeed very, very subtle. I have found with cinematic that you can accentuate texture changes. And so you see how more obvious the lesion is on the cinematic. Another example here, vascular lesion, central necrosis. Again, I'm thinking about hepatoma. This was resected. It was hepatic adenoma. So there is this great overlap between the two. Typically, the issue that helps you, it's female, it's younger. We often think about things like fibrolamellar hepatomas as younger females. And again, just another example. So it's very important when you think about it, and here's a hepatic adenoma, just to make the point, they can be large or they can be small, they can be solitary or they can be infiltrative. When they're infiltrative like this, my first thought is hepatoma until proven otherwise. So again, it can be a real challenging diagnosis. And that indeed is the point. So again, this example was a spontaneous bleed, and I'll leave you with that point. If you see a patient who has a liver mass and it bleeds, and the patient has not had trauma and the patient has not had a biopsy, the number one cause is hepatic adenoma. Number two is hepatoma. Then everything else is rare. There's been reported cases of hemangiomas. There's a couple reported FNHs. There's reported sarcomas and metastasis, but a bleed in the liver is hepatic adenoma till proven otherwise. So I'm kind of out of time and I'll stop there. Hopefully I've covered some of the basic benign or almost benign lesions of the liver, some of the important differential diagnosis points, the range and spectrum, why these lesions can be difficult at times to diagnose. When you're uncertain, MRI is usually an excellent study to perform. But again, it's recognizing this broad spectrum of lesions and how they can be challenging. And I'll stop there and thank you for your attention. So what I can do, maybe I'll do what I did the first time, is do the 2 lectures together just for the sake of time. And then we can come back and we can answer questions.
Yes, sir. Surely that's fine. Yes.
Okay, so this will be my last talk. So first, again, I want to thank everyone for staying up late at night. And I know often it's very hard to ask questions late at night or when you're listening to a lot of talks back to back to back. But if you have any questions, you can just either email me or you can just post the questions on Ctbuzz on Facebook or wherever. I do look at that every day, multiple times, and I will be more than happy to answer the questions. So this last talk is on cystic pancreatic lesions. And I think all of us see so many cystic pancreatic lesions. The biggest challenge we have are the small incidental IPMNs. And the whole question is, what do you do with them? How long do you follow them for? There are other cystic lesions, serocystadenomas, mucinous cystic neoplasm, cystic neuroendocrine tumors, and SPEN tumors. I'll spend a little bit of time about IPMNs, but again, that's something we could talk about at a separate time. Now, up to 5% of patients have incidental cystic pancreatic lesions if you look at patients over age 40. And in fact, MR says 20% of patients will have cystic lesions. The better the scanner, the more cystic lesions you will find, because often they're under 1 centimeter in size. And here's just a reference from an old MR, and that number tends to be true. 20% incidental cystic lesions. So they're indeed very common. Now, obviously, history is critical. If a patient had pancreatitis, then you're looking at the cystic lesion and you know it's a pseudocyst. Peripancreatic fluid collections, that's the subject of a different talk with pancreatitis. Common locations from lesser sac to anterior pararenal space to intrapancreatic lesions like this. This patient had pancreatitis, there's a cystic lesion. You don't worry about IPMNs or anything else. It's a pseudocyst. If you want to confirm it, typically follow this patient up 4 to 6 weeks later. The lesion will typically become smaller. Occasionally, you'll have pseudocysts, obviously in patients with no history of pancreatitis, and those can be a bit challenging. If this patient presented you and there was no history of pancreatitis, you're obviously thinking about IPMNs. So it can be a great overlap between the 2 processes. And here's just that lesion again, pushing against the patient's portal vein. Pancreatic pseudocysts, often you'll see changes in the gland, dilated pancreatic duct, edema in the gland, and classic locations like lesser sac indeed make that diagnosis easy to do. IPMNs are a challenge. It's an older population. They can be single or multiple. They can involve the pancreatic duct. Most IPMNs are branches like grapes off the duct, though you may only see the duct dilated, and that's considered a main duct IPMN. Anything above a centimeter, we typically say main duct IPMN when the duct is dilated and there's no central obstruction proximally. But typically anything above 8 millimeters with a dilated duct, you're concerned about main duct IPMN, and patients will end up with EUS. The issue with main duct IPMNs, there's a high association with malignancy, or at a minimum, high-grade dysplasia as one of the possibilities. Now, in terms of IPMNs, the classic thing for calling things worrisome, suspicious of malignancy, the larger they get, typically the Tanaka criteria, anything above 3M should be resected. That's no longer the case. We talk about interval growth. If it grows more than 2 millimeters, surely more than 5 millimeters a year, there's concern for malignancy. If it has a mural nodule, that lesion's coming out. Anything with a mural nodule, your suspicion for malignancy is high, and those lesions, maybe they'll do EUS, but those lesions are always coming out. And very similarly, patients with thick septations within a lesion, surely if the lesion septations are enhancing, that's going to give you a resection as well. Also, cystic lesions in patients who have abdominal pain or unexplained episodes of pancreatitis. There's always concern that's associated with a higher chance of malignancy, and those patients will often also be resected. The issue with IPMNs, and I won't go into it in detail, IPMNs can over time become malignant. They have pannins and they become malignant over time. Now, the reality is 97% of the IPMNs are benign. It's only 3%, but that 3% is what causes all the worry in the GI docs, in the radiologists, and in the patient surgeons. So that becomes very important. Here's your typical IPMN: water density, well-defined, communicating with the pancreatic duct. We simply, without a history of any risk factors, will simply repeat that study in 1 year. Here's another patient with multiple cystic lesions. The issue with IPMNs from a malignant perspective is that any lesion can become malignant. So one of the reasons about not operating necessarily is if you resect a lesion in the pancreatic head and you do a Whipple's procedure, the patient potentially could be developing a tumor later on in the tail of the pancreas. So it's really a challenge of how to manage these patients. We'll look at the multiple IPMNs. If the patient has a family history, the patient may get EUS. If not, the patient will simply be followed by CT or MR. If you look at the current recommendations from the ACR, you will follow the patient yearly with CT or MR for 9 years. Now, they put the lesions in the categories, and I won't go into it. They do different categories by size, but at the end of the day, you're following the patient for a minimum of 9 years, okay, which is a long time, and that's very challenging. Also, it's been shown, there was a recent article that even following patients who develop malignancies, they can develop a malignancy in between the yearly follow-ups, and by the time they present, they have spread of disease. So it's very tricky what the right thing to do is. And if you think about it, if 5% of the population have cysts and you had to follow them for 10 or 9 years, you would basically have all the scanners only scanning patients with cystic lesions all of the time. So it's a little bit challenging how to manage it. And I won't go through this, but it pays to read this article. Despite the article, I think every institution has different ways of doing things. Now, this article goes through the different sizes of the cyst and its multiple flow charts. So I'll let you look at that at your own time. But I think at the end of the day, the big conclusion is you need to follow the patients with yearly follow-up. And if patients develop any features from septations to nodularity, or they grow more than 5 millimeters, some people say 2, over a year period, those lesions should be resected. So it's not, it's a really a tough science, and the article is very well written, but you can see that the conclusions are controversial. And I will tell you that every big pancreatic institution has their own rules, including Hopkins. We even have a multidisciplinary conference where all the cystic lesions go, where we discuss the CTs and MRs, we discuss the imaging findings, and really often our recommendation is significantly different than the recommendation of where the patient came from. So it's something that I think you really need to deal with your GI guys and your surgeons in your hospital and make sure that everybody's on the same page, that everybody has the same philosophy how to treat these patients. Okay, what other cystic lesions are there? Well, serous cystadenoma is a favorite. The thing about serous cystadenoma, it's a benign lesion. Even when it's large, it's a benign lesion. Sometimes they're resected. Some surgeons will say over 5 cm they'll resect because patients can get discomfort and pain, but you're not resecting because of suspicion for malignancy. It's more common in middle-aged and older women, and about half of them, particularly the smaller ones, are detected incidentally. But other times, patients do have symptoms from abdominal pain to a palpable mass to even jaundice. The classic appearance are multiple cystic lesions, that Swiss cheese appearance, often with calcification central in the lesion. But there's a range of appearances. There's an oligocystic appearance where the lesion is purely a cystic lesion, looking very much like an IPMN when it's smaller, or a mucinous cystic neoplasm. If you sample the fluid, it's glycogen and not mucin. Patients who have mucinous tumors, those are the ones you worry about malignancy. Patients with glycogen but no mucus, there's no malignant potential. Okay, very important. And again, 3 descriptions: polycystic, honeycomb, and oligocystic, with the polycystic the most common appearance. When I talk about calcifications in the pancreas, that helps me. Adenocarcinoma never calcifies. Occasionally, in a patient with chronic pancreatitis who then develops adenocarcinoma, you'll see calcifications near the tumor. Mucinous cystic neoplasms commonly calcify around the edge. Patients with serous cystadenomas, the calcifications are central. Patients with neuroendocrine tumors, often the calcifications are dystrophic. Now, when you have oligocystic serous cystadenomas, it's uncommon, but it's a bit more challenging because it's easy to confuse with a mucinous tumor. So here's a classic example: large cystic lesion, variable enhancement. When you look at it, this is arterial, multiple, looks like a Swiss cheese appearance, right? Multiple lesions coming off the tail of the pancreas. That's a benign non-neoplastic lesion. Now, this was resected because the patient was having left-sided abdominal pain. And as I mentioned, the surgeons feel comfortable doing laparoscopic distal pancreatectomy. Here it is on the volume rendered imaging from the venous phase. At times, the cystic components are better seen on venous than arterial phase imaging. Sometimes in arterial phase imaging, you'll see other helpful signs like the hepatic artery, for example, stretched. You might see other vessels stretched, but the septations are probably better seen on venous. Here's another one: large mass head of pancreas. Again, that Swiss cheese appearance. Here you can see on the MIP imaging that the vessel is stretched around the lesion. It's called the drape sign. So if you had a cancer, it would invade the lesion. It would not displace it. Serous cystadenomas classically displace the vessel with big time stretching, which you can see very nicely here. And here it is on the washout, okay? It's important to really look at a lot of these lesions to get a feel. Here's the coronal view. Now, serous lesions, although they're benign, can compress the vessels, especially the portal vein, and even scallop the portal vein, but it's not invading it. And here's another example: the tail of pancreas, again, looking very much like the first case. That honeycomb appearance, very classic. Again, the last case sort of had a honeycomb appearance as well. The thing about the honeycomb appearance, as I mentioned, maybe venous phase is better. Here's our arterial phase. The vessel hepatic artery is stretched. Here it is as we go through. There's the septations, a little bit of mass effect on the portal vein. Another example: large serous cystadenoma. Now, one thing you do see occasionally, in this case I picked to show it, is it's not always homogeneous cystic. There can be more prominent solid enhancing components early on. So it can make you, be confused what you're dealing with. Maybe you're dealing with a cystic malignancy, but when you start looking at all of the images, you realize you're dealing with a serous cystadenoma. One thing with serous cystadenomas, they classically say there's no duct dilatation, and that's very true, but occasionally you can have duct dilatation. So if you see a pancreatic duct dilated, don't let that bother you, okay? That becomes very important, all right? I mentioned that you have this oligocystic variant, which this is an example of. I have to admit, if I read this case, I'd be saying mucinous cystic neoplasm, a very large IPMN, though I don't like an IPMN because it's too large. But mucinous tumors are commonly in the region of distal body and tail. They're well defined. They have no septations typically, though they may have linear lines within them. But again, serous cystadenomas can be oligocystic. So it's an important thing to remember. Just a very nice example of that. The solid pattern is rare, less than 5% of cases, but it's challenging. The reason it's challenging is when you have a serous cystadenoma, like this case with a solid component, if I'm reading this case, because of the solid lesion, because of The vascularity, in my mind, I'm saying, and what I'm dictating is I'm saying I'm concerned about a neuroendocrine tumor. Neuroendocrine tumors are vascular and solid, washes out a bit, but it's still solid. I'm still saying neuroendocrine tumor, but in that case, I was wrong. So again, with serous adenomas, management can be followed with when they're smaller, but when they get larger or patients are symptomatic, they will be resected. Okay. The next tumor is mucinous cystic neoplasms. Now, the thing about MCNs, if you diagnose them, they're always resected. All MCNs are considered premalignant lesions. They're typically 40 to 50-year-old females, usually in body or body-tail junction. Even though they're often large, they do not communicate with the pancreatic duct and do not obstruct the pancreatic duct. They can have thin septations due to stroma, ovarian stroma. They can look similar to the oligocystic serous adenoma I showed you. Here's a classic example: cystic lesion with thin septations, which are ovarian stroma. That's the classic finding. Here's another one, a bit smaller, middle-aged female, great location, septations. Now, if I'm doing a differential diagnosis, I'm going to say I'm worried about mucinous cystic neoplasm, but I'll say I can't exclude a serous. And if the patient was younger, something like a SPEN, solid papillary epithelial neoplasm, would also be in the consideration. But those septations are really good. The location is really good for MCN, and this will surely be resected. Again, MCNs, when they come back, the best cases, they're low-grade dysplasias, but a lot of them come back high-grade dysplasia. They're all premalignant. And if you pick them up early and you resect, you basically will save the patient's life. And here it is, just showing you the same lesion with a cinematic rendering. Here's another case. We are using AI. We're working with Microsoft, looking at MCNs, trying to predict malignant potential. They look like they're 90% accurate. We're about 60% accurate. So computers may be really helping us. This was an MCN with septations. And when I start seeing septations, I'm always worrying about high-grade malignancy or high-grade dysplasia, but this was low-grade despite all of those septations. Here's another example, tail of pancreas, one of the smaller MCNs I've seen. There's a couple of thin septations. Again, this case to me looks like IPMN. A helpful thing is IPMNs this large always have some ductal communication, or almost always. MCNs do not have dilated duct. IPMNs typically do. Here's another example, large cystic lesion. At about 3 o'clock, you see the nodularity. There's some septations here. Once you see nodularity like this, it means it's high-grade dysplasia. This was resected. This was an MCN with high-grade dysplasia. Just take a look at that lesion. It looks almost like those cystic lesions I showed you within the liver, like biliary cystadenomas. It looks very, very similar, but the solid component, any solid nodule in the wall, it surely means the patient has, at a minimum, high-grade dysplasia. Now, another lesion that's cystic that can be challenging if you're not careful is cystic neuroendocrine tumors. Now, I mentioned neuroendocrine tumors and made the point that neuroendocrine tumors are typically hypervascular. So we see lots of incidental neuroendocrine tumors. A lot of work is going on now trying to grade them as 1 or grade 2 and 3. Grade 2 and 3 need to be resected. Grade 1 can be followed. A typical rule is 1 centimeter or less neuroendocrine tumors are simply followed. Over 2 cm, always resected. 1 to 2, no one knows what to do. Again, we're using radiomics to try to determine grading. There is some work that's been published already from a few institutions that really show that CT may be good at separating grade 2 and 3 from grade 1. The thing about cystic neuroendocrine tumors, they really are great mimickers. Again, one thing you need to know is they're cystic, but they have that rim enhancement. Now, the problem is the rim enhancement may only be seen on arterial phase imaging, which is why dual phase is very helpful when you're looking at cystic lesions. Also, you can have neuroendocrine tumors that are small, that sit in the patient's pancreatic duct. and obstructed duct. So it can be somewhat challenging. Here's another example: cystic lesion, talar pancreas, thickened wall. You see some nodularity? Okay, you know this lesion is going to have to come out. So what do you think it is? Well, you could say MCN. If you said MCN, I can't argue with you. Maybe it's an MCN with high-grade dysplasia. It's not going to be an IPMN. There's no dilated duct. If it was an IPMN, it surely has malignancy within it. It doesn't look like a serous cystadenoma because the wall is thickened and the septations are thickened. This is coming out, and this was a cystic neuroendocrine tumor. Here it is, just a few more views of that. And here's another one. When you look at this lesion in the tail of the pancreas, you look very quickly. It looks to you like it's a cyst. But the more you look at it, the more you notice that there's some rim enhancement. You gotta narrow the windows. You also, I find with volume rendering, you can see volume rendering here. Because I could accentuate edges, look how obvious the enhancement of the lesion is. It's not so obvious on the axials, but it's so obvious here. Here you look at it, just say cystic lesion with rim enhancement. That's a neuroendocrine tumor every single time. Every once in a while, you can have cystic mets from renal cell, but the patient has 2 kidneys. Regardless, this is going to be coming out. And here's another example. This cystic neuroendocrine tumor, I have to admit, my first thought was a MCN, mucinous cystic neoplasm, with septations, irregularity. And I read this as an MCN with high-grade dysplasia. This was resected because that's what you have to do for MCNs, as I mentioned. But the pathology came back cystic neuroendocrine tumor. So I will say that you're not always going to be right, but regardless of those 2 possibilities, and I did mention cystic neuroendocrine because I knew enough to mention that, but either of those 2, the patient is going to be getting a distal pancreatectomy, so the patient was managed correctly. Cystic neuroendocrine tumors can be small, or in this case, you can see it's large. You can see some of the vascularity. You look at it here, big cystic component, solid component more inferiorly, and that's how the lesion looks on a coronal view. A big complex cystic lesion where the lower half is solid and cystic, the upper half is mainly cystic, but there's some prominent enhancement around the edge. Now, another lesion that, I saw occasionally, but now I've been seeing 2 cases a month are SPEN tumors. The SPEN tumors are a great chameleon. They look like many things. They can look solid, they can look cystic, or cystic and solid. Classically, they're described as cystic and solid. Most of them are young females. Females 10 to 1 over males. And we typically say in their teens and early 20s, but I'm seeing more in age 30 to 60. When they're in young patients, if I see a tumor in a young patient, I don't even look at it. The patient's 19, I'm saying a SPEN tumor is the answer. The good news is SPENs are easy to find. They're large, they're cystic and solid, up to 1/3 calcify, more common in the distal portion of the pancreas. One thing about SPEN tumors, you resect them, 90% cure rate. But let me just show you some examples. Here's a large SPEN tumor. It's cystic and solid. There's wall thickening. You can consider MCN, a number of things you can consider, but the patient was very young, so it's not that hard. Here's another one that's more problematic. There's a solid mass here. I can go through a large differential. Again, the patient was young. This was going to be resected regardless of the patient's age, but this was a SPEN tumor. One thing with SPEN tumors, it's rare to see duct dilatation, and here's just a few more images. I mentioned SPENs have calcification. So the calcifications can be in the periphery or they can be central. You can have cystic and solid components. And here's a nice example of a SPEN with a very dense central calcification. Remember before I mentioned central calcifications, particularly the irregular, you're thinking about serous cystadenoma, but SPENs can often have central calcification. The difference in this case, which made it easy, was the patient was a teenager, and the serous cystadenomas, the patients are beyond 30 or 40 years of age. SPENs can be solid and large. I don't think in a differential, I can name a number of things. Again, the age would help me. If not, you're thinking about things like neuroendocrine tumors, though It's unusual to have such a hypovascular neuroendocrine tumor. You would think about things near the pancreas, but this was coming from the pancreas. This was a SPEN tumor. And again, although it looks large, the margins were preserved. This patient had a distal pancreatectomy with negative margins, and the patient should do fine. As I mentioned, 90% of the people will be cured with surgery. The last thing I'll mention is an unusual lesion called a lymphoepithelial cyst. It's a lesion more common in men. It arises off the pancreas. It looks cystic, but often it comes from the edge of the gland, and it almost looks like it's peripancreatic, like a mesenteric cyst or a lymphangioma. They're usually incidental findings, but occasionally with pancreatitis. The thing about lymphoepithelial cysts is that if you operate on them, patients often get terrible post-op pancreatitis. So if you can recognize it, it's a good leave alone lesion. Prospective diagnosis, however, is very difficult. So, but we're getting a little bit better because we recognize there's nothing really that sits so exophytic. You look at this lesion, there's a cystic lesion by the tail of the pancreas. You think in your mind quickly, mucinous tumor, serous cystadenoma, lymphoepithelial cyst, large IPMN. When you start looking carefully at the lesion, you can see it's really outside the gland and it scallops the gland. When I see a lesion that scallops the gland, I'm saying lymphoepithelial cyst, okay? Then you won't biopsy it. They will eventually operate and just resect it when it gets large like this. But it's that scalloped appearance, it's that exophytic nature that allows you to make the diagnosis. So that becomes very important. You can see it here on the cinematic. So I've gone through a number of different cystic pancreatic lesions. And I think my point is that when you look at cystic pancreatic lesions, it's not enough to simply say the patient has a 4-centimeter cystic pancreatic lesion, advise clinical follow-up. You can't be doing that. You've got to be more specific. You got to recognize whether you're probably dealing with an IPMN and perhaps you need EUS. You got to recognize if you're dealing with a serous tumor, which typically can be left alone, or a mucinous tumor, which typically will need to be resected. You want to be able to recognize the spends, particularly because of the age of the patient. I have to admit, on the older patients, it's in my differential occasionally, but it can be a very difficult diagnosis. Again, as I showed you, things like MIP imaging, 3D rendering can be very helpful. I showed you how the 3D helps with rim enhancement, like in those cystic neuroendocrine tumors. And again, by understanding the age of the patient, again, teenagers, SPEN, 40-year-old female, MCN, over 50, serous cystadenoma. By understanding all of those features, I think you're going to be better able to reach the right diagnosis in the majority of cases and really help guide patient management. So with that, let me stop there. And I know it's late, but let me look at the some of the questions. Pseudocysts are always extrapancreatic. Any rim enhancing intrapancreatic hyperdense will be termed necrosis. That indeed is true, but you know, it's really the question when you're looking at a cystic lesion, the sequela of necrosis sometimes is simply an intrahepatic cystic component to a lesion. So, you know, it's when you're diagnosing it, it can be not quite as simple perhaps as it is, you know, from a statistical thing. One of the things to recognize with pancreatitis, when you have the history of pancreatitis, things are fairly easy, but I think all of us know, and I think your experience is probably like mine, often the history of pancreatitis is not there, particularly in an ER patient or a patient who's referred in. You just don't have all the patient's history. Okay, a question about how do you differentiate cystic mets from multiple abscesses on CT? Usually what happens with abscesses on CT, often what you will see besides perfusion changes around the lesion, often you have septations, often there's wall thickening, and also the patient is typically febrile. When you have liver lesions and they're abscesses, the patients are not afebrile. Typically Mets, the patients are afebrile. Also, you have a good history. I think there's a challenge sometimes. We've had patients with cystic lesions which ended up being abscesses post-op pancreatic cancer, which looked very much, in the right scenario as recurrent tumor, but the patient's markers were fine. And in some of those cases, the patient wasn't even febrile. So that's important to look at. Should we give hepatic adenoma a cirrhotic liver background? If a patient has cirrhosis in the liver and I see a vascular lesion, I'm saying hepatoma until proven otherwise. Hepatic adenoma typically does not occur in patients with cirrhotic liver. I guess it can occur, but to me, hepatic adenomas are occurring in liver with normal parenchyma. Any lesion I see in a cirrhotic liver, short of a simple cyst, I'm concerned about. Remember, you don't see hemangiomas in cirrhotic livers, right? Because with hemangiomas, which are basically blood pools, because of the fibrosis in a cirrhotic liver, it'll compress the hemangioma. And if you have a hemangioma, then you develop cirrhosis, the hemangioma will disappear because it gets compressed. So any vascular lesion, I will never call a hemangioma in a cirrhotic liver. I do have one or two proven examples, perhaps, but I'm never going to call that. And when I see cirrhosis, I'm not really thinking hepatic adenoma. I'm thinking hepatoma. Can we diagnose a pseudocyst without a history of trauma or pancreatitis? I think it's hard. I think I could show you some really nice pseudocysts now, particularly when they're intrapancreatic, that look identical to IPMNs. It can be really, really hard. SPEN versus serous adenoma. The biggest thing, of course, is the age. You don't typically see teenagers or 20-year-olds with serous adenomas. Most of the time you can, because SPENs commonly have solid and cystic components. So that helps you a bit. Also, SPENs commonly will have calcification, particularly around the periphery. Serous adenomas, when they have calcification, is central and stellate. So that becomes important. So I don't typically think I have a problem. I do case conference on Wednesday. Anyone's welcome to join us, but I do case conference on Wednesday. I quiz the faculty. And often I show cases that look like serous adenomas that are SPENs and SPENs that are serous adenomas. So sometimes you just can't get the right answer, to be honest. The age thing helps, but particularly as we're seeing more SPENs in 40-year-olds and 50-year-olds, it can be a very tough diagnosis. Okay, FNH versus fibrolamellic. I think the biggest thing is with FNH, the enhancement is homogeneous. Fibrolamellar typically are vascular, but it's a regular enhancement. It's a much more closer to arterial phase. Remember with FNH, I said the lesion's homogeneous. Fibrolamellar is not. The other thing is with fibrolamellar, they're more vascular, looking more arterial, and FNH is really going to match the IVC. So I don't think it's typically going to be a problem. Is it possible hemangioma does not follow blood pool density? I guess in theory, but 90% of hemangiomas are classic. There's a few cases of hemangiomas which can be really, really difficult. I think that the most difficult ones are the smaller ones. The second most difficult ones are the ones with flash filling, where you don't have peripheral puddling, but you think, oh my gosh, I'm dealing with a primary or a metastatic lesion that's small. So you're not always going to be perfect, but 90+% of the time, I think you will be. Let me see what else there is. I think that SPEN thing I answered. I think that's all the questions. Is again, if you guys think of more questions, feel free to email me. My email is efishman@jhmi.edu. I do answer my email, but if you put it on Ctbuzz, I will get to it. And I wish I could be in India with the rest of you guys now, but hopefully in a year or so we'll be back in business. But again, we on Ctbuzz, as mentioned, I do appreciate the plug, but we don't sell anything, so it's not a plug for business. But you can see a lot of cases there, and I think for the fellows and residents on the call, my experience when I was trained, and I think this part has never changed, is you got to look at a lot of cases. And one way of looking at the web is wonderful, whether it's our site or other sites. The web is wonderful for looking at cases. You can look at Instagram. You can look at Facebook, you can look at websites, just look at a lot of cases. I think you get a much better feel of the spectrum of disease when you do that. So I again, thank you all for inviting me. And someone asked my email. So it's E Fishman, like Elliot Fishman, but it's E, just the letter Fishman, Fishman. And it's at JHMI, Johns Hopkins Medical Institutions, jhmi.edu. Okay.
Yeah. Thank you,
All
sir.
right. All
Yeah,
right,
it was
guys.
wonderful. It's been a wonderful teaching experience for all of us here. Thank you very much for being part of this. And we'll look forward to inviting you to India perhaps next year or the year after, very surely.
Okay. Sounds great.
Thank
Okay.
you very much, sir. And goodbye. Yeah.
Bye.
Okay, after Dr. Fishman, we have Dr. Karthik Ganesan once again. And this is again a really wonderful topic and a topic very close to Dr. Karthik's heart. This is on LIRADS. So I'll just check if Karthik is online. Yes, he's there. He started the screen share, so we'll start shortly. Karthik, I need you to be your sound.
Yeah, you can hear me now?
Yes, perfect. Yes.
Yeah. Okay, so I think it's late on a Saturday, and I think we'll kind of rush through this lecture, looking at certain salient features of LIRADS. What I'll try to do is break it down into about 5 parts. What exactly is defining where you can use LIRADS, that is the definition of an at-risk liver. Explain to you what exactly is LIRADS. It's a guideline. It's not an absolute. Nothing in imaging or in medicine is an absolute. You need to tweak the guidelines to how your institution kind of works and collaborate with your clinicians and your MDTs. Just look at the AASLD LIRADS algorithm. Focus on the diagnostic table, only on the arterial phase enhancement component. And of course, I'll run through a battery of cases to see how it kind of works in clinical practice. So what's very important to remember with any kind of a staging or a guideline algorithm is that you should know where to use it and where not to use it. And I teach my fellows or my residents that where you should not use LIRADS. And there are 2 subsets of patients. One is pediatrics, and the second is Budd-Chiari. Pediatric, because there's yet a lot of work to be done on the spectrum of tumors, and HCC is not the dominant pathology which you see in these patients. And in the Budd-Chiari spectrum, simply because it's very common in South Asia, Southeast Asia, and the veno-occlusive disease, the so-called parent pathology of Budd-Chiari, tends to have a myriad of presentations, especially in its subacute and chronic phases, where you tend to get these large nodules or NRHs, which can mimic or mirror the morphology as well as the temporal enhancement characteristics of HCC. So you need to be careful when you use it in certain subsets beyond where it's supposed to be used. So typically, we don't use it in pediatrics and in Budd-Chiari. You can use it in the rest of the situation if you have a known chronic liver disease. So what are the top causes? Viral hepatitis, Hep B, Hep C, alcoholic liver disease, non-alcoholic fatty liver disease, and then of course a myriad of pathologies like Wilson's, hemochromatosis, and so on and so forth. But please remember, don't use it in the pediatric and the Budd-Chiari population. One important terminology changes. We don't describe nodules as nodules or as lesions or as masses or tumors. We describe them as observations. Ideally, we report the top 5 observations depending on the probability indices in any kind of a cirrhotic liver or at-risk liver. So don't use the word nodule, use the terminology observation. Like I mentioned, LIRADS is not an absolute staging system or a particular stratifying system. It is basically a risk stratification assessment based on certain imaging features, especially the temporal enhancement characteristics, based on which you have a probabilistic index whether this observation, which you see in the at-risk liver, is going to be an HCC or no. LR1s are typically benign, and LR5 observations are definitively HCC. Now, why am I going to stress on the word definitively HCC? It's very important to understand this concept that whenever you use the terminology LR5 in an at-risk liver, it's near certainty or with a very high degree of specificity that this observation is going to turn out to be an HCC. Now, what is that percentage of specificity? It can vary, but ideally at our place, it ranges from between 96 to about 100% accuracy in diagnosis of HCC. Now, what is the offset of this? Though all LR5 observations, or nearly all of them are HCCs, not all HCCs are LR5s. Now, this is something you've got to remember, that because of a very high specificity using these particular scoring systems or these kind of imaging features, your sensitivity tends to drop by, and therefore you don't pick up all the HCCs which don't have all the typical features. Now, which are the ones which you don't miss or which you miss? One would be hypo-enhancing HCCs, HCCs with rim enhancement, or what we call the rim-like enhancement or the peripheral enhancement. Those HCCs form the oddball out, even infiltrative HCCs, which don't show the typical pattern of enhancement. Now, for LIRADS, the major criteria are the observation size or the nodule size, whatever you want to call it, and the temporal enhancement features. We look at the enhancement on the arterial face, which should be non-rim-like, the washout, which is non-peripheral, and the presence of an enhancing capsule. Please remember that a capsule may not be seen in all HCCs. Smaller the size, lesser the chance you're going to see a capsule. Larger the observations, higher the chance you're going to pick it up. More common to see HCCs with capsules in the Indian subcontinent or in South Asia, Southeast Asia. The North American and the European counterparts, you don't get to see a capsule as much. Again, please remember, the capsule can be continuous, discontinuous, irregular, or partially seen, but whether you see it or not, if it's seen, any amount of it is seen, it will be partial, incomplete, or discontinuous. That means there is an evidence of a capsule. Now, we don't go to categorize this further, whether there's a breach in the capsule or it's a discontinuous capsule, it doesn't matter. Of course, yes, prognostically, the tumor is more invasive, the capsule is breached. Because of a diagnostic, it does not change much at all. Now, please do remember that if I don't give contrast, and I just use the non-contrast sequences, which is the T2 characteristics, the T1 or the diffusion, and what is called as the ancillary features or the ancillary criteria, I can only scale the observations from LR1 to LR4, and I cannot label it as an LR5. So technically speaking, you need contrast to complete your study and therefore be able to categorize or characterize an observation or a nodule. Failure to give contrast due to many reasons. It could be A, patient's got a contrast allergy, patient refuses contrast, or the patient has got an underlying renal dysfunction, potential NSF candidate on hemodialysis. You know that you want to be safe with these patients. You may not give contrast. So how do you overcome this? You can overcome this pretty easily. You can do the contrast enhanced ultrasound or a targeted contrast enhanced ultrasound, and you can kind of try to categorize or characterize this observation, because the contrast used in ultrasound is not affected by the underlying renal profile. Now, that's something which is not going to be part of this lecture. I will touch base at a later time on this. Please do remember that the development of HCC is not a single time point, but are assessing these observations over a period of years. Ideally speaking, when you have an atrous liver, which is now migrating from a normal liver. So for example, a normal liver has got a dominant portal venous supply. So suppose you've got chronic active hepatitis moving towards F1 fibrosis, F2, F3, F4. Now that level of cirrhosis, what's going to happen is there's going to be development of regenerative nodules, micro or macro regenerative nodules. Ideally speaking, the parent liver or the regenerative nodules tend to have identical vascular supply. So typically what would happen is these observations or these RNs, which are dark on the T2 weighted images, they may or may not be siderotic, tend to have a dominant portal venous supply. But as they tend to change in their morphology, RNs start to develop dysplastic foci. They may start to become high grade or dysplastic nodules or observations. You would see a change in the milieu of the vascularity, which is supplying that portion of the liver which has got that dysplastic nodule or that dysplastic focus. And therefore, what you see is a change from a portal venous vascularity or a portal venous dominant vascularity to the liver to a dominant arterialization of that observation and the adjacent parenchyma. This change in vascularity kind of mirrors the change in the cellular pattern or the changes in the microscopic milieu of these observations, where you tend to get a grade of dysplasia and then a potential HCC developing in. So that means normal liver has got a high portal venous supply and a lower arterial component, but as the grade of the observation tends to move upwards, the arterialization component increases. So if I want to kind of look at that from a point of view of LIRADS, typically LR1 and LR2 observations are benign observations. LR3 kind of forms the intermediate observation, where you have a combination of arterioportalization of these observations. So you will see some amount of capillarization, neovascularity, but it won't have all the features what you would start to associate it with either a focal HCC or a large HCC, which I'll be tabling or labeling as a pathological HCC. When you have small HCCs, they're typically about 10 millimeters or smaller in size. Larger ones tend to have the sine qua non features of HCC. So please remember that carcinogenesis is not a one-time point process, but it's a multi-step process with the change in both the microscopic milieu as well as the vascularity of these observations. Now, please remember this crux of change from an LR3, which is typically those arterial enhancing observations, which you to see dime a dozen in these livers, to an LR4, which is early or a potential early HCC, is a very, very important phase. And that is actually called the development of pathological capillarization of these tumors. So I'll kind of run through this in a very important form. So what is this change in vascularity, and what does it impact, or how does it impact the way we image these patients? So please remember, normal liver changing into mitotic disease or tumorigenic or neoplastic disease, that phase is called capillarization, where you get dynamic changes in not just the vascularity, but even the basement membrane and the non-tumoral supporting cells. Now, this is a pretty complex issue, and a lot of work is happening on that. And what I would like to say in a kind of to summarize this is that there is a change in the endothelial cell and the bridging complexes which bind the endothelial cells with the basement membrane. So typically what happens is some of these endothelial cells tend to lose certain important markers like ICAM, CD32, and stabilins, whereas they also gain something called a CD34 marker. Now, when this change happens, this change is absolutely critical, because that's a change from a benign condition like an RN to a more pathological angiogenesis, which potentiates the growth of HCC. Now, please understand this concept pretty well. And why I'm going to tell you this is, it'll change the way you image your HCCs. With better scanners, both on MR and the CD front, there's a tendency to go on a very early arterial phase. When you go too early, what happens is the contrast remains primarily in the aorta, as well as the celiac trunk and the common and proper hepatic artery. But this contrast does not have enough time to reach into that arteriocapillary and the capillovenous component. Now, as you have seen on this prior slide, capillarization is absolutely important for change in the milieu of these cells. So for that capillarization to be picked up, that neovascularity, that neoangiogenesis to be picked up, you don't need to go too early on your contrast phase. And therefore, we use that dictum, better late than never. So in all our patients, we tend to have only a late arterial or an arterioportal phase, simply because you want the contrast to get away or get out of the artery, get into the capillary, and there you identify the capillarization or the neovascularization. And from there, you start to see the capillovenous network. So a good arterial phase is actually a late arterial phase where you've got good contrastation in the arteries, but you also got some amount of venous admixture within the portal venous phase. So this cellular mechanism is represented in the way you actually have your imaging technique set up in your hospital or in your center. So please remember, high-grade dysplastic nodules are typically LR3 observations when they migrate towards small HCC. So typically 10 millimeters or slightly smaller than those. That form of angiogenesis is an incomplete angiogenesis or is a sinusoidal form of capillarization. But as the lesion, the observations grow in size, the capillarization becomes more diffuse. It's not localized to one area, and that's called complete pathologic angiogenesis. and that impacts the way we actually assess these observations. Please remember this, that HCCs which are small tend to have abnormal capillarization, but it's not as robust as what you would have with large HCCs, or what we call as pathological HCCs. This early capillarization, which may be seen on your contrast phases, is also termed dormant angiogenesis. And what it means is it allows for local growth of HCC, but it does not potentiate angioinvasion and therefore metastases beyond the confines of the liver. At the same time, when the HCCs start to grow up, the pathologic angiogenesis tends to be more vibrant, more voracious, and potentiates the growth of HCC into the vessel itself, allowing it to be pro-metastatic, so a higher propensity of vascular invasion and also extrahepatic spread to organs or even to the peritoneal cavity, and so on and so forth. Now, please remember that as tumors grow, they have a lot of vascular heterogeneity, and that's due to a lot of factors, which I'm not going to touch base out here. But along with increased vascular heterogeneity, you tend to get a lot of permeation, which is allowing for the tumor to disseminate. Due to these complex changes in the vascularity and the cellularity, tumors actually have a marked heterogeneity as they tend to grow more than 2 centimeters in size. They may have a mosaic morphology, a nodular nodule, a necrotic component, an area of ischemia, fibrosis. It's a pretty complex morphology, and I won't be getting too much into that. Now, once I've shown you what is capillarization, what are the important features you need to look for, this is the Lyrad's ASLD algorithm, and this basically tells you that how we've used or how we incorporated Lyrad's into the ASLD algorithm itself. Prior to 2018, Lyrad's was a standalone radiology document supported by the American College of Radiology. It was made by radiologists to be used by radiologists. Of course, there was a clinical input as well as an output in part of it, MDTs. But as of 2018, Lyrad's got merged into the ASLD algorithm, and we were able to be part of clinical algorithms for the first point in time. Why I've kind of put this slide up there is that we have spoken about surveillance and the role of ultrasound in surveillance itself. In a country like India, ultrasound is the best tool to actually serially monitor or even what you would call for patients to undergo surveillance. However, if you read literature, especially in the last 2 to 3 years, you are seeing a subtle change in momentum towards non-ultrasound techniques to be used in surveillance. Now, the dominant technique amongst that is MR, though it's restricted to some institution, what we call as abbreviated scanning protocols. Now, the abbreviated scanning protocols are of 2 types. One where you can use contrast, and that contrast is typically not an extracellular agent, but an intracellular agent like UVist, or you could have a non-contrast technique which could be used as a surveillance. So that would be just a T2, a diffusion, and a T1. And the need for these abbreviated protocols have come simply because of the need to shorten the scanning times. However, please do remember, these protocols are not sacrosanct. They are all based on individual-centric or hospital-based practices, and you need to refine them before you take it forward. The money component or the main component of the diagnostic Lyrad's table is just this one single page, which is, I think, the page 8 or 9, which kind of reflects how you use it in your day-to-day practice. Now, if you look at this small diagnostic table, it doesn't have too much packed into it, but there's a lot of significance in this table, and I'm going to concentrate on the right side of the table. This is a little more complex. I won't be getting into it at this point in time. On the right side of the table, which is mentioned as non-rim apathy. So now I'm going to explain to you certain things. When you're looking at the enhancement features of HCC, if you get to see a peripheral or a rim-like pattern of enhancement, usually the diagnosis is going to shift away from HCC to non-HCC malignancies. Now, in a cirrhotic liver, you would be asking me, why would you think of malignancies other than HCC? But I would tell you, you do get to see the following phenotypes often in a cirrhotic liver or an at-risk liver. And those could be cholangiocarcinomas, intrahepatic mass forming, primary lymphomas of the liver, metastases, which can also behave similarly. Now, all these 3 entities can have rim-like pattern of enhancement, on the arterial phase. Now, another example of metastases would be neuroendocrine, but even primary neuroendocrines can have that pattern of enhancement. So, to have a very strict rule or diagnostic criteria, we remove the word rim like AFI and we use the word non-rim like AFI. So what is non-rim? The tumor will enhance everywhere except peripherally, or even if it enhances peripherally, there would be heterogeneous enhancement within the core of the observation or the lesion. Now, once you've got that pattern of enhancement on your late arterial or arterial portal phase, the second thing you need to look for is the size of the observation. Now, please remember, most classifications use 20 millimeters as a cutoff until the 2018-19 unification. Following the unification of LIRADS with AASLD, the size cutoff for HCCs has now been brought down from 20 millimeters to 10 millimeters. So that's a very important part of the unified algorithm. Less than 10 millimeters, these are usually observations which you don't have a great clue. You don't have a great amount of specificity to go and say that this is going to be an HCC, and you have to have these patients under a careful watch and under surveillance and call them back, repeat the imaging, and decide whether you need to take this forward. Do you want to scale the observation to an LR4 or an LR5, or just maintain, is it an LR3? What I'm going to do is, once I've kind of briefed you on this thing, I'm going to run how I kind of do this on a day-to-day basis. So I'll show you one case, probably 10 different cases or 10 different observations, and I'll show you how it kind of works on a day-to-day basis. So let's look at this one. It's a 51-year-old male with an actress liver, Hep B positive. Now, please remember, Hep C patients tend to allow you a lot of time to diagnose HCC. That means a Hep C patient will go from a chronic active hepatitis to fibrosis of varying stages, F1 to F4, cirrhosis, and then HCC. Hep B behaves kind of differently. It kind of bypasses the step of fibrosis and cirrhosis. And from chronic active hepatitis, you may straight away jump to HCC. Now, please remember to see large amount of HCCs in our population in Hep B positive patients, and the liver looks pretty normal. It will not look cirrhotic, or there will not be any much of features of chronic parenchymal disease. Now look at this, pretty interesting. Hep B positive, so you know it's an atrophied liver. And now let's look at the observations and how we tend to work on this. So the first thing I tend to do is I keep only the top phases, the arterial, the portal, and the hepatic venous phase. Typically, this is acquired between 25 seconds and the hepatic venous phase at about 2 minutes. So within those 2 minutes, I acquire these phases and I look for the temporal phasicity of how this observation is behaving during those 2 minutes of scanning time. So let's look at what happens on the arterial phase. So here, you can see that the pattern of enhancement is not just peripheral, but you can see squiggly vessels getting in, and there is patchy areas of enhancement on neovascularity within this. That kind of array of vessels getting in is sine qua non for an HCC or an LR5 observation. Now let's see, how do we measure this? You're used to measuring observations of lesions in the liver in 3 dimensions: transverse, anteroposterior, as well as superior inferior. In LIRADS, you just measure the single largest dimension on the axial section of the transverse section. So when I measured it on the axial section, the observation measured 84 millimeters or 8.4 centimeters. So if I would look at the table, this is non-rim AFI. I would go to the extreme right. It's greater than 20 millimeters. And now what I would look for is for the other features. The other features which are there are, is there any washout? Yes, there is washout. And plus, what else do you see? Is there an enhancing capsule which is persisting? So when I have 5 features, which is non-rim AFI greater than 20 with the remaining 4 features of enhancing capsule and washout, I would kind of just fit it into the algorithm, and this would fit into a classic LR5 observation. So when I'm reporting this, I don't report it too fancily by reporting the T2 characteristics or the T1. I just report that there's an 84 millimeter observation showing a particular pattern of enhancement and washout with or without a capsule. This represents an LR5 observation. Now, why did I kind of show you this as the first case? I'm showing you this as a first case because when you use a combination of these 3 factors, size, non-rim AFI, and non-peripheral washout with or without a capsule, the percentage specificity to the diagnosis of HCC is near 100%. Now, this data, where I've kind of put it in outline in black in red, talks about our data itself over the last 12 years on chronic liver disease. And we have about a 96% specificity to the diagnosis of an HCC. It's kind of bumping up slightly higher. Certain observations which showed very late washout or did not show a uniform pattern of washout were actually the problematic cases in our spectrum, which turned out to be either atypical cholangios, hepatic cholangiotumors, what we call collision or combined tumors, or even sometimes HCC with lymphomas, which can behave in a very, very unusual pattern. We also saw hepatocellular carcinomas with neuroendocrine differentiation, which can also cause some degree of problems when you're looking at it. But by and large, when you use only these two criteria, your percentage specificity is really as good as it can get with any kind of an imaging modality. Now let's look, I mentioned to you about nodule size or observation size and the capillarization. What is the other factor which tends to affect the pattern of enhancement and the pattern of washout in HCCs? And that is the differentiation of the tumor itself. So broadly speaking, HCCs are either well, moderately, or poorly differentiated. I just want to get in a point out here. No tumor is homogeneous in their microscopic appearance. The dominant phenotype or the dominant appearance would be either well, moderate, or poorly, but usually there is an admixture of other components also within that observation. Now, what is the impact of this pattern of differentiation on the pattern of enhancement and washout? Please remember, small HCCs or small, usually below 2 centimeters, the arterial phase hyperenhancement is not as robust as you would see with larger HCCs and moderately differentiated HCCs. Poorly differentiated HCCs tend to enhance less to a significant amount or a significant extent with a higher quantum of ischemia and necrosis with it. Now let's look at the washout component. When you're looking at washout, poorly differentiated tumors tend to show a much higher degree of washout simply because of the significant amount of disruption in the endothelial lining, very vascular rerouting of which comes out in these tumors. So the shunting is rapid and you tend to lose a larger amount of blood or contrast, which is within the blood pool outside of the tumors itself. So please remember, moderately differentiated tumors, small sized tumors tend to enhance voraciously. Poorly differentiated tumors with large amounts of ischemia as well as necrosis, the periphery of these observations tend to wash out more robustly as compared to well-differentiated HCCs. So the first case highlights how you would see a classic. Now let's look at case 2, something which is not as big, but this is right now in the dome of the liver, segment 8, stroke 7, and let's see how the lesion or the observation measures. I'm not focusing on that satellite nodule on this observation, just focus on the larger one sitting up here. And when I measure it, you can see that it's about 17 meters. It shows arterial phase non-rim-like enhancement with a classic washout and a faint enhancing rim. And now what you get to see is this observation. Sorry, I'll just go back again. That's for the smaller one. I'm not going to be talking about that. The larger observation is also an LR5 sitting up here. Now let's go back to case number 3. Case number 3 out here, you can see a little more exophytic. In segment 6, it's 25 millimeters in size. And because it's 25 millimeters in size, it's showing a kind of a heterogeneous enhancement. There is a definitive washout and the capsule is kind of enhancing on the portal and the hepatic venous phase. So if you kind of go onto the table greater than 20 millimeters, 2 features including washout and enhancing capsule, you know this is an LR5 or a classic HCC or a definitive HCC sitting up here. Now I've got a couple of pointers to tell you out here. As per as the LIRADS algorithm, the washout must happen in these 2 phases or pretty early on in the temporal enhancement characteristics of the tumor itself. But what we see in our setting, especially in the Indian subcontinent, is that the washout may not happen so early as compared. It may happen probably at 3 minutes, 4 minutes, or even 5 minutes. Now, because of that slow washout, and that may be due to a particular differentiation pattern of these observations, we are forced to scan these patients for a much longer time. That's one of the deviations which we tend to use as compared to the standard LIRADS algorithm, that washout is not defined purely in the portal of the hepatic venous phase. It may be seen much later as well. The second point which I want to highlight to you all is the capsule, though it may be seen in small lesions or small observations, typically observations which are generally more than 3 centimeters, not only the 2 centimeter cutoff, 3 centimeters or beyond have a higher propensity to capsule formation rather than smaller observations. So tomorrow, if you're scanning a patient, you have enhancement and you have washout, but you have no capsule, so you can still call it an HCC or an LR5 observation if it fits into the 10 to 19 millimeters or greater than 10 millimeters itself. Let's look at another observation within the same liver. 20 millimeter size observation in right lobe segment 6. Now, what do you see in this? Look at the pattern of enhancement. You have an enhancement which is happening in the periphery as 2 distinct dots. It's not a continuous rim. So the definition of a peripheral rim-like enhancement or a rim-like pattern of enhancement is when you tend to get a homogeneous, smooth rim of enhancement or even an irregular rim of enhancement. If you tend to get these small puddles of enhancement and some amount of centripetal enhancement also on the arterial phase, not a progressive centripetal enhancement, that would also categorize or characterize for heterogeneous non-rim-like aphy. And when you look at it on the venous phases, you can see that there's a drop in intensity of enhancement, though the core of this observation has retained some degree of contrast, but now there is development of a peripheral enhancing rim. Now, when you put these again, you have heterogeneous non-rim-like aphy. So you have a combination of enhancement or heterogeneity on the arterial phase. You have some degree of washout and you have a smooth enhancing rim. That would definitely fit into another LR5 observation. Pretty much similar pattern of enhancement. One more, which you're seeing in segment 6. Oh, sorry, this will be segment 8. And again, note the pattern of enhancement which you see. You see this kind of squiggly areas, small areas of neovascularity, which you tend to see not only within the core of the lesion, you might even see these arc-like patterns of enhancement. Now, please remember, when you see capsular enhancement, though which could be discontinuous, is best appreciated on the venous phases, typically on the hepatic venous phase, and you can see the homogeneity of the capsule. Of course, the capsule could be discontinuous and broken down, but ideally best appreciated on the venous phase. Whereas the pattern of enhancement which you tend to get on the arterial phase is not the capsule enhancing, but it is the periphery of the observation of the tumor itself, which is enhancing out here. So this again fits into a non-rim-like pattern of enhancement. There is a non-peripheral washout. Now again, remember this term, even if there's arc-like enhancement and then the rim persists or the capsule enhances, if this capsule actually washed out and there was a core of enhancement filling up, it would actually get into a non-peripheral washout, which is more typical of a cholangiocarcinoma rather than an HCC. So this, again, when you look at this pattern, in arcs, centripetal as well as peripheral enhancement with washout and a delayed enhancing rim fits into another pattern of LR5 observation or an HCC. Now that we've kind of identified the 20 millimeters and beyond, you need to start focusing on the smaller guys. You get to see a lot of this in your atras livers, in your cirrhotic livers, and you always call them as perfusion anomalies. You might call them as TIDs or TADs, whatever you want to call them, but you need to look at them very carefully. And especially with MR, you see a dime a dozen more than on CT. So here, let's look at this observation, which is right next to the right hepatic vein. And this observation measures 5 millimeters in size. So when you go to the table, you have now got the greater than 20, you got the 10 to 19, but here is the less than 10 spectrum. Now, please remember, as a standard dictum, when you have an observation less than 10, you cannot call it an LR5 observation or a definitive HCC. So what can you call it? So if this observation on the venous phase, if you look very carefully, is showing a degree of washout, which is accentuated on the hepatic venous phase, and the observation looks very hypointense as compared to the rest of the liver. So what is this observation? Like I said, you can't call it an LR5, but if this observation, which is enhancing on the arterial portal phase, shows washout, you will call it an LR4. Now, what is an LR4? LR4, technically speaking, represents a probable HCC That means if you wait for some amount of time, it's going to grow in size. It's going to be more than 10 millimeters and going to satisfy the criteria of calling this HCC. So please remember, if you had seen this to be a 15 millimeter or a 30 millimeter lesion, and this lesion had enhancement and washout, you would call it an HCC. But just because it's less than 10 millimeters, because of the guidelines, you cannot call it an LR5, you'll call it LR4. What is more important is, what is the recommendation you will be giving to your MDT or your tumor board? And that's critical, that once you label any observation as LR4 or probable HCC, you need to get this patient back onto your table within 3 months. At our institution, we don't wait for 3 months. We actually get these patients between 8 to 12 weeks back onto the scanner, knowing that these patients are definitely going to go into HCC, because we would then do a targeted ablation, either in the form of a TACE or even an RF or a microwave ablation, and take out these observations. Let's look at, now that you saw a sub 10 millimeter showing washout, let's look at the more commoner ones which you see in your clinical practice. Less than 10 millimeters, it's a 3 millimeter arterial enhancing observation. And you can see that there is no washout. Typically, these would fit into your standard LR3s. These observations need to be followed up within 6 months, ideally between 3 and 6. But our institution, we push the gauntlet and we say that we'll go towards the latter part of the number, that we go towards 6 months. Another example of the same. On the same slide now, you can see the observation, which is here, which is 5 millimeters showing washout, but the observation seen more ventrally to this observation is not showing any obvious washout. So this also forms an LR3 observation, and we would put the patient back very critically. Now, please remember that though there are these stringent guidelines, you need to have your own institutional-based variations. But what's more important is that whenever you're reporting using the LIRADS algorithm, you need to use the recommendations also accurately. So I'm revisiting that. When you have LR3 observations, you must recommend that the scan and the patient be taken up to MDT. There should be a discussion. And ideally speaking, you need to bring these patients back onto the table within 6 months. It's between 3 and 6, but we generally go and push it a little more after 6 months. Now, why do we use 6 months as a cutoff? 6 months is the time when you start to see threshold growth. Now, how do you define threshold growth in a nodule or an observation? If there is more than 50% increase in the diameter of the observation within 6 months, that would stand for threshold growth or qualify for threshold growth. That is the reason why we use 6 months as a cutoff. For LR4, we need to be a little more aggressive. Usually, we would either give a follow-up or a biopsy, but because these observations are so small, you can't see them so easily on CT. We advise a very close follow-up imaging within 3 months. I would like to kind of finish this entire thing on LIRADS just by summarizing this for you guys. Please remember, LR5, the positive predictive value or the specificity to diagnosis is as high as about 98.5%. That means if you say LR5, this is going to be an HCC. Let's look at an LR3. If you say an observation is LR3 and you follow this patient at 6 months, there's a potential chance that about 35 to 50% of these observations would have grown in size and they have the potential likelihood to become HCC. The one in between is the LR4, which we called as probable HCCs. And these are definitely HCCs, but just because of their size, we cannot call them as HCCs. So typically they're below 10 millimeters, showing enhancement and washout. So what you need to do is aggressive follow-up, less than 3 months. And that's the reason why that when we say an observation is LR4, literally 4 out of these 5 observations are going to convert and become into definitive HCCs. So I've kind of summarized the entire thing and how we kind of work and use LIRADS on a day-to-day basis. But very important to remember that as residents and as faculty, you need to tweak your protocols and your guidelines as per your institutional practices and your MDTs. So I think with that, I'll kind of end my lecture. Thank you so much for a patient hearing. If you have any questions, I'm more than willing to take.
Thank you, Dr. Karthik, for an exhaustive talk on LIRADS. I think there is a question in the question and answer session. How to differentiate HCC from hemangioma on case 4?
Okay, so it's pretty much easy. A hemangioma typically would show four, depending on, of course, the types, but we just generally would label them as hemangiomas. If you take a standard hemangiomas, you would say that there are four basic features: peripheral, discontinuous nodular puddles of enhancement on the arterial face. Now, that peripheral enhancement, that nodular enhancement should coalesce, or they should all aggregate together, and the whole lead, the contrast should start filling in centripetally. So what would happen is the nodules which are enhancing will remain persistently enhancing. They will grow and they will increase in size, and the whole lesion will start to fill in. Now, typically what it means is that means the enhancement is there on the arterial face, but there is no washout but progressive enhancement. HCCs are completely different. HCCs will show a heterogeneous pattern of enhancement. The intensity of enhancement never parallels the blood pool, and the enhancement will show washout. So once you see washout in an observation, you cannot label that as a hemangioma. That's a standard way of differentiating HCCs from hemangiomas.
I think that's quite a detailed explanation. There is one more question: how to differentiate regenerative and dysplastic nodules?
We don't use the term RNs and DNs any longer when you're using LIRADs. We just use terminologies as LR3s, LR2s. So RNs are by definition are benign or LR2 observations, which would be typically iso-enhancing to the parenchyma. There will be no arterial phase enhancement in these observations. They may or may not be siderotic, so you could see T2 susceptibility on your susceptibility weighted images or your Dixonian techniques. If you go to dysplastic observations typically would be T1 bright. They would be generally larger than the surrounding observations. So typically micronodular cirrhosis, the observations are between 2 and 10 millimeters. Dysplastic nodules tend to be on the larger side of them. The T2 signal is going to be lower, but they may show arterial enhancement with or without some degree of washout. So enhancement, T2 signal, and the T1 signal, you can differentiate the three entities.
Okay. Another question: will fibrolamellar HCC type morphology be classified into LIRADs?
No, FLCs are not part of the because FLCs typically happen in a you would say in a liver which is not at risk. They happen in normal livers, so you cannot use LIRADs for FLCs.
Okay. Can we give LIRADs in a patient with BCS or a patient with no features of cirrhosis?
You cannot use LIRADs in BCS or veno-occlusive disease. That is a major exclusion part of the LIRADs criteria. Yes, you may have a normal looking liver, but you may have a background risk factor. Now that could be chronic active hepatitis. It could be an underlying alcoholic liver disease. Could be a NAFLD, non-alcoholic fatty liver disease, which you can have a normal liver with fatty liver or a fat infiltration of liver, and you can have HCC coming up over there. So a relatively normal appearing liver does not exclude an underlying parenchymal disease. So you can use LIRADs.
And I think the last question is washout defined with respect to liver parenchyma or arterial phase HU?
That's a great question, but typically it's a temporal enhancement of the observation itself, but with respect to the parenchyma. So, for example, if I were to let's give a standard example of what happens in terms of an HCC. So, typically, what would happen is the liver gets contrast. The lesion gets contrast on the arterial phase. The background liver is not enhancing. Now, as soon as the background liver starts to get portal venous phase, the liver is going to start to enhance far more, and the lesion is going to go down further. So ideally, what I do is I make an intrinsic comparison with the lesion itself. I don't use the background liver for my washout.
Okay. So I think that was the last of the questions. Thank you, Dr. Karthik, again for both your exhaustive talks and for answering the questions so patiently and in detail. As usual, we have learned a lot from your lectures. Thank you again, Karthik. You can stop sharing your screen. Our next speaker is Dr. Atin Kumar. Dr. Atin Kumar is a professor attached to the Trauma Center at AIIMS in New Delhi. He's been 16 years as a faculty. He has got more than 200 journal article publications and more than 31 chapters in books. He has delivered more than 130 invited guest lectures. He is the National Head of Emergency and Trauma Radiology Subspecialty of IRI. He's been conferred the J.C. Bose Memorial Oration, the N.G. Gadikar Oration, as well as the V.P. Lakhanpal Gold Medal. He is going to speak about CT and abdominal trauma. Welcome, Dr. Atin. Can you please start sharing your screen?
Thank you, Dr. Zubair. Thank you, Sanjeev, for this opportunity. I'm glad to see more than 200 people still at this time of the late Saturday evening. So let's try to keep you awake still. Okay. So in this next 30 minutes or so, I'll be speaking on CT and abdominal trauma. Trauma is, we all know, the leading cause of mortality in less than 45 years of age, and it's the fourth overall. It affects basically young people, right? Because these are the people who are mostly on the roads, mostly who are working, and trauma is something which is related to usually accidents or fall from heights. It could be blunt or it could be penetrating. In the blunt category, the motor vehicle accidents, assaults, and even fall from heights are the most common etiology. Whereas in the penetrating trauma, stab wounds or gunshot wounds, penetrating wounds are the ones which we get to see day-to-day activity. When we talk about abdominal trauma, in blunt trauma, these are the two main organs which are by far most commonly affected compared to any other part, the spleen and the liver, almost equal, spleen more than the liver. Whereas in stab wounds, the liver, just because of its sheer size, becomes the most commonly affected organ, and followed by stomach, because it's usually the epigastric stabs which are actually done, followed by small bowel and colon. Whereas in gunshot wounds, it's most commonly the small bowel which gets involved. So coming to the role of imaging. Before I talk about role of imaging, I would like to tell you about American College of Radiology has given certain appropriateness criteria for how to image patients of abdominal trauma. First of all, the patients are actually categorized into three different categories, A, B, and C. I'll tell you what are the three categories. Category A are the patients which are hemodynamically unstable patients. So these are categories based on the clinical scenario of the patient. Category B are the patients who are hemodynamically stable. Either they have been stabilized or they were stable to start with itself. At our center, at most of the dedicated trauma facilities, these patients are managed in a totally different area of the ER. In our ER, this is a red area, which is the area in which we basically examine and image category A patients, and the yellow area is the one in which we image the category B patients. So category A patients are the one who are hemodynamically unstable, usually unresponsive. What we do as an imaging in these patients is just a fast ultrasound and radiographs of chest and pelvis. Usually there is not enough time for these patients to be subjected to a CT scan, and based on the findings of the fast and the radiographs and on the clinical findings, if they are suspecting abdominal trauma, these patients go directly to the operating room without further imaging. However, if they become hemodynamically stable, then you may get a contrast enhanced CT scan done to further characterize these patients also. Then they actually become category B later on. Category B patients are the one which are hemodynamically stable patients, right? So they also undergo the same fast ultrasound and radiographs of chest and pelvis. And depending upon the findings of the fast ultrasound, or depending upon the mechanism of injury also, even if they are hemodynamically stable, most of these patients get subjected to a contrast enhanced CT, which is the mainstay of diagnosing the abdominal injuries in these patients. Then based on the findings of the contrast enhanced CT scan, they further undergo management, which is dependent upon the clinical status as well as the radiological findings. And I will tell you in detail as I go along that the various interventions that can be done are surgery, angiographic embolization, or a non-operative conservative management. The category C is actually a stem out of category B, a special category of patients in which we suspect a urinary tract injury. Basically, these patients, if we are suspecting a urethral injury by having a blood at urethral meatus or floating prostate on digital examination, should undergo a RGU first, and if it shows a urethral injury, should undergo a suprapubic cystostomy. If the RGU is clear, then a urinary catheter per urethra is put in, and the CT of the abdomen and pelvis is followed by a CT cystogram in these patients to rule out a bladder injury. And depending upon the findings, the patients are further managed. A couple of slides about fast ultrasound, which I was saying. So fast is focused assessment with sonography for trauma, and we often do E-fast, which is extended fast, in which we also include the pleural cavity and the lungs in the ultrasound examination itself. Its point here to remember is it's a targeted ultrasound done rapidly and done at the bedside. And the main aim of all this ultrasound is to detect fluid. Fluid in the peritoneal cavity, fluid in the pleural cavity, fluid in the pericardial sac. And any fluid in the peritoneal cavity indicates hemoperitoneum. In this setting, we classify it as fast positive or fast negative. A fluid in the peritoneal cavity is hemoperitoneum, that is fast positive. Fluid in the pleural cavity is extended fast positive, and it just means that the patient requires further evaluation to look for organ injury. Do we use ultrasound to detect the organ injury, the specific injury? No. The sensitivity is low. That means it may fallaciously not pick up even free fluid. So negative fast should be interpreted as indicating the absence of hemoperitoneum, but not the absence of intra-abdominal injury. Either you may not pick up the hemoperitoneum properly, or hemoperitoneum may not have formed if the injury is limited to the organ capsule and not going out. Second takeaway point from fast is positive fast does not necessarily means an operative case. It just means there is hemoperitoneum. Whether that hemoperitoneum is significant enough for an injury which requires laparotomy, that is dependent upon the clinical situation of a patient, the clinical hemodynamic stability, as well as the subsequent findings on the CT scan. And it's point to note is we do not use fast for detecting organ injuries. We do not want to use it for liver injuries, spleen injury. There, more than 50% of them are missed on routine ultrasound scan. And moreover, the other organs like the bowel, the retroperitoneum, the mesentery, the diaphragm, these injuries are not detected on ultrasound. So let us not use ultrasound to detect the specific organ injuries. It is limited only for the purpose of picking up free fluid. One point here is, can we use ultrasound to pick up injuries, organ injuries? If at all, you have to use ultrasound. If you do not have a CT available, but if you want to image or manage the patient, then a contrast enhanced ultrasound may be done. Again, this is better only for picking up solid organ injuries better, but it still will not pick up bowel injuries, diaphragmatic injuries, retroperitoneum injuries. The contrast enhanced ultrasound, I'm showing you one example. We've been using it in our center in a research scenario, basically, or limited uses. So the liver, plain liver does not maybe pick up any injury, just shows maybe slight heteroechogenicity. But if you give contrast, you can, in the same area, you can clearly see that there is a hypo-enhancing linear area, which is the laceration, and the patient subsequently underwent a CT, which confirmed the laceration. So a contrast enhanced ultrasound is thus showing promise, but however, because of its limited availability, it still cannot substitute a contrast enhanced CT scan. CT scan remains the mainstay, and the protocol which we follow is no requirement of oral contrast. In the trauma setting, we do not give oral contrast, not required. We may give rectal contrast in significant pelvic injury or in a perineal penetrating injury. So very limited role. What we do is we usually do a dual phase CT in all cases which are fast positive, which have a significant mechanism of trauma in which we are suspecting a positive abdominal finding. So we take a arterial scan right from the neck till the pelvis. So it's for the chest and the abdomen. We call it a torso scan, complete torso scan in the arterial phase. And we do a venous phase limited to the abdomen. We exclude the chest in the venous phase. We may do a delayed phase in specific scenarios when we are thinking of a vascular injury, or maybe excretory phase when we are thinking in terms of a kidney injury. Then we take a delayed phase, which is 3 minutes down the line. However, if there is a low suspicion of abdominal injury and the CT is being done to basically rule out rather than rule in abdominal injury, then we want to reduce the amount of radiation. So we just do a single venous phase, which may be typically done in children where we want to give less radiation. In fast negative cases where the suspicion of injury is low. Pregnant women, we all know we can do a CT in pregnant women, but we still want to reduce the radiation. So we just can do a single phase. Or if significant time has elapsed since trauma, we're not thinking in terms of a significant arterial injury, then we can just do a venous phase itself. Coming to the grading, the American College of Surgeons in combination with Advanced Trauma Life Support actually have given an organ injury scale, the AAST classification, American Association for Surgery and Trauma. OIS imaging scales have been given for the various organs. They have been recently updated in 2018 for the liver, spleen, and kidney. They are present for all organs, for all abdominal organs at least. And these three have been updated in 2018. And that's what we will try and see in all the organs. These organ imaging scales actually use certain definitions of the patterns of injury to make a grading, grade them into various types. So let's first understand and study what are the different patterns which we use, or the definitions which we use to put them in these grades. For the all solid organ injury, be it liver, spleen, or kidney, or even pancreas, these are the common injury patterns. And let's see one by one. So contusion or a parenchymal hematoma is basically an area of hypodensity in the contrast enhanced CT scan, which is not enhancing as much, has usually ill-defined geographical areas. As you see on this axial and the coronal scan in this liver, these are the areas of contusion. In the contusion, you may have vessels passing through them. However, if you see almost no vessel passing through it and it's much more well-defined, much more hypodense, we typically call it as hematoma. These are the spectrum of the same type of injuries, contusion to hematoma. There is not much differentiation between the two, except just a radiological pattern. This is contusion, slightly indefined, like you say about GGO in the chest versus a proper consolidation in the chest, which means like a hematoma or a more hypodensity in the abdomen here. So in this case, it's in the liver. In this case, it's in the spleen. These are the hematomas and these are the contusions, right? The hematomas can be subcapsular rather than parenchymal. So in this case, what you see is a subcapsular hematoma, which is a hypodense, which actually indents over the parenchymal surface. So if the parenchymal surface is deformed, it is subcapsular. Like in this case, it's seen in the spleen also, subcapsular hematoma deforming the parenchymal surface. Then the next terminology is laceration. Laceration is an ill-defined but a linear hypodense non-enhancing part in a solid organ. It may be zigzag, it has got irregular margins, maybe single, maybe multiple. Like seen in this case in the spleen, this is linear, this is a laceration. Again, in a coronary format, in the spleen, usually extending from one surface, maybe the peripheral surface, maybe the central hilar surface, longitudinal, and you need to measure this laceration. This is seen in the liver, right? So this is extending from the peripheral surface of the liver right till the porta. This is a laceration. See the hemoperitoneum also, which is present. Again, the point where I'm keeping here is I'm not saying it as ascites or fluid. I'm just saying fluid only, but I call it as hemoperitoneum in the setting of the trauma. If I see a hyperdensity within the hemoperitoneum, this does signify that there is definitely a bleed, and a hyperdense focal area of bleed means a sentinel clot sign, means the blood here has clotted. If you see this, like you see hemoperitoneum here also in the interloop, also Morrison's pouch also, but in the perihepatic area, you see the hemoperitoneum which is hyperdense. This is the sentinel clot. This sign has got significance because it signifies that the area which is bleeding is close by only. So if you see hemoperitoneum all around, but if you see a sentinel clot in one area, you know the area, the organ adjacent to it is the one which is likely bled. In this case, it was a liver laceration which had led on to a sentinel clot here. You may not see this in all cases, but whenever you see, it gives you a clue, right? A large area of lacerations or contusions put together may lead to what is known as a lobe disruption. So if you see maybe an entire lobe or multiple segments involved, not enhancing, maybe kind of devascularized, this is known as a complete disruption of a lobe. Like in this case, it is the right lobe disruption. Then there can be devascularization. Devascularization, as the name suggests, means non-enhancing of the entire parenchyma of the organ. So means infarct. So in this case, there was a left kidney infarct as well as a splenic infarct. You may or may not see a occluded vessel, but if the whole organ is non-enhancing, you call it devascularized. There may be a partial devascularization also when it is partially non-enhancing. Then coming to vascular injuries, they are also now included in the solid organ injuries scale for AAST. So let's look at the vascular injuries. The vascular injuries are divided into uncontained and contained vascular injuries. Uncontained means when the contrast is leaking out of the vascular wall, which means there is active contrast excitation, which means active bleeding going on at the time when you're doing a CT scan. Vis-a-vis a contained vascular injury is when there is a pseudoaneurysm or arteriovenous fistula formation. So let's see at the examples and the definitions. How do you define or recognize a vascular injury? By vascular injury, I'm calling out a contained vascular injury. They are basically focal collections of contrast. They remain same in size but decrease in attenuation in the delayed phase. Whereas if the hyperdensity increases in size or spreads to adjacent area and in attenuation in a delayed phase, it is the active bleeding. Let's see at examples. I'm showing you one arterial phase of the CT scan. In this, you see hyperdense linear irregular areas which do not look like normal vessels, but they are vascular, but they are the contrast which we give in the vessels. They are like the vessel, they like the contrast in the vessels. So this means this is contrast outside the confines of the vascular wall. This is active contrast leak. How do you confirm it? You do another phase. If you've done the arterial phase, you take the venous phase. If you're doing the venous phase as the first phase, you take immediately another phase just a minute later. If you see the same areas diffusing out, changing in shape, spreading, maybe slightly decreasing in the attenuation, then these areas signify that there is active contrast leak, because this is the contrast which has come out of the blood vessel diffusing out. So this is active contrast extravasation. Contrast this to another example. In this case, you see a lobular contrast density. This is not a normal vessel, but if you take a delayed phase, the shape remains the same. However, the attenuation decreases. The attenuation follows the pattern of attenuation of a adjacent vessel. In this case, you see this follows the attenuation of aorta here, follows the attenuation of aorta even in a venous phase, follows the attenuation of aorta even in a delayed phase. This is a contained vascular injury, or what we call as a pseudoaneurysm, also seen best on this VRT images, right? So these are the different types of vascular injuries. Once we've known how to pick up these injuries, let's talk about specific organ injuries one by one. Spleen is the most vascular organ, most commonly injured organ. I've told you. What you want to do is you want to pick up all the injuries and then classify them into various grades given by AAST. This is a complex chart. We use it day in, day out, so we do remember it, but it's a good idea to keep it handy. Maybe place it next to your console, a printout, and then you can actually put all these observations in the various grades. So let's see, how do we pick up lacerations? I've told you lacerations less than 1 centimeter. If it is, it will come into grade 1. You measure them. If it is more than 1 centimeter, it will come to grade 2. If it is more than 3 centimeters, it will come to grade 3. Whereas subcapsular hematomas, they typically dependent upon how much surface area of the splenic surface they are abutting. So if it is less than 10%, grade 1, 10 to 50% is grade 2, and more than 50% is grade 3. Whereas a parenchymal hematoma, again, grade less than 5 centimeter is grade 2, or more than 5 centimeter is grade 3. So depending upon the size of these observations or these pathologies, you can actually put them in the various grades. In the vascular injuries, I've shown you examples. If you see a pseudoaneurysm, right? This is a pseudoaneurysm. This is usually classified as grade 4 in the new AAST OIS, or this is also a pseudoaneurysm. This example I'm showing you to tell, especially in the spleen, sometimes you can see a pseudoaneurysm or a pulp injury only in the arterial phase, but if in the venous phase, you may not pick it up. So there is a role for doing a dual phase CT in a suspected splenic injury and taking a good arterial phase. However, the parenchymal injuries are best visualized on a venous phase. As we all know, the heterogeneous enhancement of spleen on the arterial phase makes it difficult for us to recognize the true parenchymal injuries. Vascular injuries on the arterial phase, parenchymal injuries on the venous phase. Coming to active bleed, I've shown you examples earlier. This is a contrast density leaking outside, and on a delayed phase, this diffuses. If it is localized to the spleen parenchyma, again, this is grade 4. But if it is going out into the peritoneum, you need to identify, because it then changes the grade. Lastly, devascularization. If the entire spleen is not enhancing, or even a part of the spleen is not enhancing, the different grades given to it. This is almost grade 5, and the entire devascularization, or even a shattered spleen is grade 5. You almost do not see any part of the parenchyma. Only patchy part of parenchyma is seen, a large hematoma surrounding and involving the entire spleen. This is grade 5 splenic injury. What's the importance of these grades? It just signifies that higher the grade, the more likely the patient may be having difficulty in doing undergoing a conservative management. Conservative management is the key which is done nowadays. We try and do more of conservative management rather than operative. However, patients of higher grade will have more chances of failure of conservative management, or patients with vascular injuries, the pseudoaneurysms, the contrast exercises, they are likely to have a failure of conservative management. They would typically require intervention, either in the form of angioembolization, if it is available, which in our center we commonly do, or otherwise then operative repair, which is by splenectomy. So I'm showing you example of a large hematoma with a patient which did have multiple pseudoaneurysms and contrast exercises. We went ahead and did a splenic angiogram, confirmed the extravasations. We placed coils in the proximal and the selective, and a splenic artery embolization was done. So, and CT not just diagnoses, it also helps in therapeutic management by picking up injuries which are amenable for endovascular embolization, and splenic artery embolization plays a very important role in management of these patients. Liver is the second most common organ injured. This is again almost a similar type of a organ injury scale given for liver. You can go through it. I have taken this diagram from Radiopedia, but again, important here is to pick up lacerations, again, measure them, because the measurement of laceration grades them in from grade 1 to grade 3, picking up subcapsular hematoma. Again, the size of the subcapsular hematoma increases the grade from 1 from grade 3, and intraparenchymal hematoma. In this, there is a contrast exercise also. The size of hematoma, again, less than 10 centimeter versus more than 10 centimeter, increases the grade from 2 to 3. A contained active bleed, you need to pick up. I've shown you this is almost a big area of disruption of the right lobe, but has an active contrast leak on the arterial phase. On the venous phase, you see this increases in size. A pooling is almost seen. So this is active contrast excitation. This is classified as grade 3 if it is limited to the liver parenchyma within the capsule. However, if there is contrast extravasation which is seen to go into the peritoneum outside the liver capsule, it is classified as grade 4. These are the arterial phase scans. These are the venous phase scans in which this extravasation is slightly increasing in size. If there is lobar disruption, again, depending upon the extent of lobar disruption, they are classified as grade 4 or grade 5. If it is less than 75%, grade 4, more than 75%, grade 5. In this, it is almost a grade 5 injury because there is more than 75% disruption of the liver parenchyma. A special scenario in the liver is what is known as a juxtahepatic venous injury. You need to identify any laceration which is reaching up to the junction of the IVC with the hepatic veins, because these lacerations which extend into this have a tendency to involve maybe one of the hepatic veins or the IVC. In this case, this laceration here was extending and involving the IVC with a rent in the IVC, a partial thrombus in the IVC. Once you identify this, however small the laceration may be, this is classified as a grade 5 because these are high chances of morbidity and mortality. Obviously, higher the grade, higher is the chances of morbidity, mortality, higher the chances of failure of conservative management, even in the liver injury. So you need to pick up these specific abnormalities. Again, there is a role for hepatic artery embolization. We at our center significantly and liberally use angiography, DSA, and embolization techniques to maybe stabilize these patients. This was one case in which there was active contrast excitation in the peritoneum as well as the liver, and it showed active contrast excitation on DSA, and it was selectively coil embolized. High-grade liver injuries or vascular injuries, pseudoaneurysms, contrast excisations are usually subjected to a hepatic artery embolization at our center as the first priority before they think of doing a packing for the liver by surgical option, right? So we do a significant number of hepatic artery embolizations at our center. There may be some delayed complications. It may be either a hemobilia, like you can see some hyperdensity within the biliary tracts. It is usually associated with a significant liver parenchymal injury, or if there is bilious damage because of a significant liver injury, there may be collection of bile, which is known as a biloma formation. It is a delayed complication of a liver injury. If gets infected, it may be drained by pigtail drainage. Coming to the third solid organ, the renal injury. It's the second most common organ injured. In fact, it's the third most common organ injured, actually. And this is again organ injury scale grading, AST grading, which has been given. This is a beautiful diagram from Radiopedia. You can go through it later on, but I'll again be showing you the examples. In kidney also, you can have a subcapsular hematoma, which is classified as grade 1. There is a perinephric hematoma is classified as grade 2, especially limited to the girotas fascia without any significant active bleed. However, if there is active bleed confined to the girotas fascia, in this case, there was a pseudoaneurysm which was bleeding out with the bleed localized to the girotas fascia. This is classified as grade 3. Or if there is active bleed, in this case, it is active contrast excitation with a significant perinephric hematoma, entire left lobe, the inferior pole of the left kidney is shattered. This is a venous phase in which I can see this contrast is diffusing out and increasing here. And even a delayed phase, a 3-minute phase, shows a significant amount of contrast pooling. This all contrast is extravasated outside. So this is the active bleed outside girotas fascia, classified as grade 4. This is seen very well on this VRT image. And this patient was hemodynamically unstable, underwent a nephrectomy, and this is an operative specimen, in fact, confirming exactly the same what we told on the CT images. Usually, again, all renal injuries are managed conservatively. However, it's the patient's clinical status. If the patient is hemodynamically unstable, they may require nephrectomy. Otherwise, most of these lesions are actually managed conservatively. Lacerations, if they're less than 1 centimeter, they're classified as grade 2, or they are more than 1 centimeter, reaching up to the PCS but not involving it, they're classified as grade 3. However, if the laceration is running through and through the PCS and involving the PCS, it is classified as grade 4. How do we know it involves the PCS? We take a delayed scan, excretory phase. If we see excretory contrast outside the confines of the kidney, like seen in this particular case, a calyceal injury was seen here. This is classified as grade 4, and this is important to diagnose it because this will require usually some form of urinary diversion, either a PCN or a DJ stent in situ to help in management of this pelvic calyceal injuries. Then there can be vascular injuries in the kidney in the form of segmental artery. It can lead to an infarct in a part of the kidney, and this is a segmental infarct classified as grade 4, or there may be a complete infarct of the kidney by a complete thrombosis of the proximal renal artery. So a renal infarct with a proximal renal artery also classified as grade 4 if there is no bleed associated with it. However, if there is a complete infarction or a complete shattering of the kidney with arterial extravasation bleed, then it is classified as grade 5 renal injury. These may be requiring some form of angio intervention. We go ahead and do an angioembolization in these patients. Otherwise, they usually do not require nephrectomy if the patient is hemodynamically unstable. Right. Coming to pancreatic injury, pancreas, one thing important to note is, although CT is the modality of choice, but CT may be falsely negative in some set of patients. There is a role for MRI in pancreatic injury. In fact, MRI plays a role only in the pancreatic injury in the setting of abdominal trauma, right? Let's see some examples. Before that, I'll again showing you the organ injury scale of AAST for pancreatic injury, and I'll show you as I go along what are the different types. The grade 1 is small areas of contusion or small lacerations which are minor, not involving the main pancreatic duct. Again, contusion is seen as a hyperdensity. In this case, subtle hyperdensity in the neck. We did confirm by doing a MRI. There was a subtle altered intensity in the region of the neck, and the MRCP did show that the duct was intact. So this was a grade 1 injury. However, if there is a major contusion or a major laceration, still not involving the main duct, it is classified as grade 2. So as we can see, there is a laceration here on the inferior surface of the pancreas. There is peripancreatic fluid, signs of pancreatitis. But if I do a corneal reformat, I see that this laceration is involving less than 50% of the depth of the pancreatic parenchyma. So in all probability, not involving the main duct. Once it is not involving the main duct, this laceration or even a small contusion would be classified as a grade 2 pancreatic injury. However, if the laceration extends and involves the main pancreatic duct, or the contusion, large contusion involves the main pancreatic duct, it's classified as grade 3. So we see this, a large area of contusion in the tail of the pancreas, right on the CT scan. We went ahead and did a MR. We could see this large area of contusion as well as a laceration running through it. This was involving the main pancreatic duct. This was classified as a grade 3 injury, especially seen in the region of the body and the tail of pancreas, that is to the left of the confluence of the SMV with the splenic vein. The splenic vein and the SMV confluence is taken as the direction. Anything to the left of it is classified as grade 3 injury, or anything to the right of it, if it is involving the main pancreatic duct, is classified as grade 4 injury. In this case, there was a laceration in the head of the pancreas that is to the right of the confluence of the SMV and the splenic vein, which was involving the main pancreatic duct. This is a grade 4 pancreatic injury. Grade 5 pancreatic injury is a shattered head of the pancreas. Almost non-visualization of any viable part of the head of the pancreas. Obviously, the pancreatic duct, the CBD are all involved in this case. Lots of signs of the peripancreatic inflammation. And a follow-up CT done 10 days later shows almost a formation of what looks like acute necrotic collection, like which will form a pseudocyst at a later on time. Importance here is, if there is involvement of the pancreatic duct, usually these patients will have significant peripancreatic collections and they may require a surgical intervention. If it is to the left of the SMV splenic vein confluence, usually a distal pancreatectomy is done if it involves a main pancreatic duct. And if it's to the right of the confluence, many of these patients undergo a Whipple's procedure. Although our conservative management have significantly improved nowadays, that we can actually try and avoid Whipple's even in the cases of grade 4 injury towards the right of the pancreas. However, we should know that involvement of the duct may require a close observation, and these patients may require a operative intervention. Sometimes a ERCP guided pancreatic duct stenting can also be done if the duct can be negotiated as a mechanism of correction. Sometimes we get late patients. This is one example in which you all have a laceration of the pancreas with a big collection which is formed. This was done some 20 days post-pancreatic, post-abdominal trauma, right? Adrenal injury is a very small component, insignificant. We may see large adrenal hematomas, but they usually are not of any significance unless they are bilateral and enlarged. Coming to the more important part is a bowel and a mesenteric injury. These are one of the most difficult injuries to diagnose. CCT is the best modality more than anything else. However, CCT is also still not very sensitive or very specific in picking up these injuries. We may miss it. CT is good for liver, spleen, pancreas, even diaphragm. Bowel, it is the best, but not as good as other organs still. So it is one of the challenge. And why is it a challenge? Because bowel injuries are one which do require operative intervention. They cannot be managed conservatively. So the onus lies on the radiologist to pick up these injuries. Obviously, in conjunction with the clinical scenario and the findings, rigidity, guarding, and the hard abdomen, the tense abdomen, the clinicians will tend to do at least a laparoscopy, if not a laparotomy, even on their clinical suspicion. But we as radiologists will aid them. How do we look for bowel injuries? We look at signs which are specific signs or not so specific signs. There are various signs which are described, but these are the ones which are slightly more specific for bowel injury. Pneumoperitoneum, focal bowel wall discontinuity, intramural layer, focal extraluminal layer adjacent to the bowel lumen, or a contrast leak, vascular contrast leak, or interbowel fluid. Let's see them one by one. So pneumoperitoneum is a clear-cut sign that there are chances of bowel injury. So if you see pneumoperitoneum, even if you do not see bowel injury, we think that there is a bowel injury, and the patients are usually taken up for at least a laparoscopy, and if the clinical signs are also present, laparotomy. The only other chances of there can be pneumoperitoneum without a bowel injuries, maybe pneumomediastinum extending into the peritoneal cavity, or a stab wound, an open wound which gives rise to a peritoneal violation and external air going in. Other than that, pneumoperitoneum signifies a bowel injury. In this case, we were lucky enough to see the most positive sign of bowel injury, that is discontinuous one of the walls of the bowel, in which the bowel content was seen to go out and leak into the mesentery. So this was classical sign of a bowel injury. However, we are not so lucky, as I'm showing you in this case. Most often what we just see is pneumoperitoneum and focal bowel wall thickening, or maybe some diffuse bowel wall thickening without a focal bowel wall discontinuity. We just tell that there is most likely bowel injury, and depending upon which bowel loop is showing slight thickening, we may tell that most likely some ileal loop or maybe a proximal jejunal loop is the bowel which is most likely to be injured. Even if we are not able to specifically tell which part of the bowel is injured, it's fine. We need not require. Even if we just tell there is pneumoperitoneum, there are signs of clinical, the patients will be getting operated. However, if we are specifying, it's good. Like in this case, we do see a mesenteric injury also. There is a mesenteric hematoma. There are focal patches of air adjacent to one of the lower ileal loops here. And this bowel loops are also showing mild hyperenhancement. In this case, we did say that most likely there is a distal ileal loop which is showing injury, may be associated with a mesenteric injury. The patient was operated. It did show a mesenteric injury with a focal ileal perf. So we do have a good correlation with CT in terms of the site of injury also in some cases. Showing you another example. In this particular case, we saw that one of the bowel loop was gangrenous, was not showing enhancement. Part of it was showing enhancement. Then there was a abrupt change in the terms of the enhancement. So we knew that in this case with pneumoperitoneum, this is the loop which is most likely perforated. We also have the liberty of using a dual energy CT scanner, which is available in our trauma center. A dual energy CT scan can actually better visualize and pick up these non-enhancing areas by the iodine overlay maps. So this gives us a confidence that this is a non-enhancing bowel loop. This patient was again subjected to surgery, and a non-enhancing, non-viable bowel loop was again confirmed along with the mesenteric injury. So I'm showing you examples just to show that mesenteric injuries are often associated with bowel injuries. They go hand in hand, not necessarily always, but often. Another example, this is just what I'm trying to show you, is you may actually miss pneumoperitoneums. You need to sometimes do a change in the window settings to pick up minimal pneumoperitoneum, because if you miss pneumoperitoneum, that is not done, because these are the patients who, if missed, will actually deteriorate fast, and you are not allowing the surgeon to operate them early enough. Mesenteric injury is often associated. The most clear-cut sign is a mesenteric bleed, active bleed in the mesentery, whereas we sometimes do see large amounts of hematoma in the mesentery also. These are the signs of mesenteric bleed. All mesenteric injuries, significant, usually require an operative intervention. Many of them would at least undergo a laparoscopy and followed by laparotomy or a laparoscopic repair itself. if required. In this case, there was a significant mesenteric hematoma along with the bowel loop, which showed abnormal enhancement. Again, this patient was subjected to a operative repair, a large mesenteric tear with a bowel loop, which was also not showing the normal enhancement. So we do have a good correlation. Coming to the last couple of slides of my talk, the urinary bladder. This is one component also which we need to evaluate. I've told you these are the category C patients, patients with hematuria. The bladder injuries are commonly associated with pelvic fractures, and you have ruled out a urethral injury by doing a RGU. You've put in, the clinicians have put in a urinary catheter per urethra or a suprapubic catheter. Only after that you can evaluate the urinary bladder. What we do is we do a CT cystogram. We do not take a delayed phase and allow the contrast, excreted contrast from the kidneys to fill up the bladder. That is not an evaluation technique for evaluating urinary bladder. You need to instill contrast through the urethral catheter or the suprapubic catheter. Distend the bladder with 300 ml of contrast mixed with saline, and only then you repeat a CT scan. So if you see, there are the different types of bladder injuries, but what's most important is picking up bladder rupture. The type 2 is the intraperitoneal rupture, which is usually from the dome. The contrast leaks out and opacifies the peritoneal cavity in the interloop area. This is intraperitoneal rupture. Important to pick this up because intraperitoneal bladder ruptures are a clear sign for operative intervention. These are repaired operatively. Extraperitoneal injury is one in which the bladder tears at the lower part, not at the diaphragmatic surface, not at the peritoneal surface, but at the extraperitoneal surface. The contrast leaks into the prevesical and the perivesical spaces. This is extraperitoneal rupture. This can be managed by just a Foley's catheter in place. However, there can be sometimes combined injury, which is classified as type 5, in which there is both intraperitoneal injury, which is at the dome, as well as extraperitoneal injury at the base. A combination of this will still require operative repair, especially for the intraperitoneal rupture. Lastly, retroperitoneum. We need to pick up retroperitoneal injuries also, not miss up. Retroperitoneal hematomas are usually associated with vertebral injuries or pelvic injuries, but you may have a significant vascular injury. In this case, there was an aortic dissecting pseudoaneurysm, best seen on this VRT image also. Lastly, abdominal wall injuries also you need to pick. In this case, there was active contrast extravasation. Sometimes you do see abdominal wall hernias, which may be seen in blunt trauma also. There may be a herniation of the bowel loop, but they are very commonly seen in penetrating injuries. So in the penetrating injury, you need to look for peritoneal violation as well as herniation of the abdominal contents outside. Or there may be moral levaline lesions, which are basically internal decurving, where you have large areas of hematoma within the subcutaneous tissues. These are also to be picked up radiologically because they also will require some operative repair. So just to summarize in the end, most of these patients are managed conservatively by a non-operative mechanism, but there are certain indications for operative repair. So you as a radiologist have the responsibility to pick up at these not to be missed findings, which change the management from a conservative to a management which requires intervention. Bowel injury, vascular injuries, pancreatic ductal injury, renal pelvic calyceal system injuries, intraperitoneal bladder rupture, and lastly, diaphragmatic injury. These need to be picked up. I'm not included in my today's talk. I will include it in my tomorrow's talk on chest trauma because diaphragm lies in between the two. I've included in my chest trauma, but this is the important component. If you just remember these and all vascular injuries which require. So I'd like to conclude here by saying CCT is a valuable tool for evaluation of all hemodynamically stable patients, and we need to look out for signs that predict requirement of surgical or angiographic intervention. And obviously, we need to classify all injuries by AAST organ injury scale. These are some of the references. This is the article about the new update, and these are some of our articles which we have published. We've extensively published on abdominal trauma from our center. These are all our publications. You can actually go through them. Thank you so much.
Thank you, Atin. That was really wonderful. And there are a couple of questions which have come up, and a couple of them I can just, I hope you can answer right now before we move to the last lecture of the day by Zubair.
Sure.
Amol is asking type 3 interstitial bladder injury. Please rewind.
For the lack of time, I actually did not show a type 3 interstitial injury. I maybe will show subsequently later on. It
Okay.
usually does not require operative intervention. Therefore, I actually kind of skipped it. It is basically hematoma in the wall of the bladder,
Okay.
and it maintains the shape of the urinary bladder.
All right. There's one question by Akshit. It's a little long, but I'll just read it out. If a contusion or laceration is passing through the hepatic or portal vein, but it's contrast or pacified and no contrast leak, can you call this juxtahepatic venous injury?
Yes, all hepatic vein injuries, especially in the part which they are closer to the IVC, are classified as juxtahepatic venous injuries when the laceration is reaching up to the vein and maybe extending into the vein. You can see one wall of the vein at least showing the continuation of the laceration, or maybe a small thrombus attached to the wall. It is classified as juxtahepatic venous injury.
All right. Okay. Okay. There's another. Ramandeep is asking any other cause of pneumoperitoneum other than bowel perforation.
Yes, I said that clearly. Extension of air from pneumomediastinum, from the chest into the peritoneal cavity, can occur through the normal pores, through the aortic hiatus, through the esophageal hiatus, or especially if there is penetrating injury, if there are stab wounds, bullet wounds, and there is a peritoneal violation, then the external environmental air actually can go in. Or if it is a post-operative or a drain has been put, then there can be pneumoperitoneum in this setting. And last, but an interesting scenario which we have ourselves seen in our practices, when Foley's catheter has been put in a urinary bladder, which we normally put before we subject the patient to a CT scan, and if there was a intraperitoneal bladder rupture, usually during placement of a Foley's catheter, some amount of air typically goes in the bladder along with the Foley's catheter at the time of putting the catheter. If there is an intraperitoneal bladder rupture, that air will leak out and go into the peritoneal cavity. So a intraperitoneal bladder rupture can also be a sign of pneumoperitoneum.
Okay. One more question from Ramandeep. If the linear hypodensity is not reaching the liver capsule, will it still be a laceration?
Yes, lacerations usually involve the capsule, but they may be limited to the parenchyma itself. We see very commonly lacerations limited to the parenchyma, not reaching up to the capsule.
Okay. Akshit is asking a lot of questions. Okay, so let's keep going.
No issues.
So Akshit is asking, how do we differentiate between subcapsular and perirenal hematoma?
Subcapsular hematoma, I can go back to the example. In any organ, will change the shape of the organ, will indent the organ margins. The organ itself will show indentation, whereas perihepatic, perisplenic, perirenal hematoma will not change the shape of the organ. The shape of the organ will remain intact, and the hematoma will be in the same shape outside the organ margins.
Okay. Great, Atin. Thank you for answering all those
Thank you.
questions and for a wonderful lecture. We'll see you tomorrow once again with
Sure.
the chest trauma. Thank
My
you very
pleasure.
much.
Thank you so much.
We now welcome Zubair Qazi for the last lecture of the day. And sorry, Zubair, it's run a little late, but we still have many people here. So we are happy to have this lecture from you. So Zubair is a senior consultant radiologist at Saifi Hospital, Mumbai, and has been practicing since the last 19 years or so. He is a recipient of many awards, which include a Cum Laude Award at RSNA 2015 and the Distinguished NBE Young Achiever Award. And he's a postgraduate teacher as well for the National Board of Examinations. And his areas of interest include GI and geoimaging, as well as MSK and cardiac imaging. His talk is today on CT urography. Over to you, Zubair.
Right, Sandeep, can you hear me?
Yeah, we're clear. Yeah.
Yeah, thank you for the kind introduction. After this huge buffet of talks by Dr. Fishman and Dr. Karthik and Dr. Atin, it's left to me to serve you the dessert. And that's going to be a talk on CT urography and predominantly its role in papillary and callicial lesions. Now, the European Society of Urogenital Radiology defines CT urography as a diagnostic examination optimized for imaging the kidneys, ureters, and bladder with thin slice MDCT, intravenous administration of contrast medium, and image acquisition in the excretory phase. Now, in the 20th century, intravenous urography was the mainstay of imaging the genitourinary tract, but it had a lot of problems, such as presence of overlapping structures like bowel, inability to understand complex anatomic relationships. All this with the development of MDCT urography was obviated, because you could get thin collimated data of the entire urinary tract during a short single breath hold. Also, MDCT urography simulated the appearance of IVU. So it was easier to read. You could understand complex anatomic relationships easily. And most importantly, both the renal parenchyma and the urothelium both could be evaluated with a single comprehensive examination. Hence, CT urography has essentially replaced intravenous sonography in most imaging practices. Now, the learning objectives of this talk is going to be, just a minute, let me just get my pointer. So we are going to describe normal anatomy and nautical variations of the renal papillae and calycils, which may simulate pathological process. We are going to discuss various CT urographic techniques which can help us in detecting subtle papillary and calyceal lesions. And we are going to discuss a few examples of renal papillary and calyceal lesions and the appearance of CT urography. Now, first, coming to the technique. As you know, technique is most important, because if you don't acquire a scan properly, you might miss picking up fine lesions. So the first thing that you do in CT urography is take an unenhanced plain CT scan. And this helps us in detecting calculi, any fat-containing lesions, parenchymal calcifications, and also assesses the baseline of lesions. After taking a plain CT, we give non-ionic contrast, which is usually about 100 ml of 300 milligram iodine concentration contrast at about 2 to 4 milliliter per second. And then there are 3 phases in which we acquire images. The first is the corticomedullary phase, which is generally 30 to 40 seconds, and it helps us in detecting hypervascular lesions. The second is the nephrographic phase, which is about 90 to 100 seconds, in which the cortex and the medulla enhance most, and this is most optimal for detection and characterization of all renal lesions. And third is obviously the excretory or the pylographic phase, which is 5 to 15 minutes after the IV injection. And this is basically for evaluation of the urothelium and the entire tract. Now, there are some alternate techniques which have been described, basically to limit the radiation exposure with the number of scans that we do. One is the split bonus technique, in which you give an initial 30 to 50 ml of IV contrast, followed by about 80 to 100 ml of IV contrast 4 to 10 minutes after the first injection. And then you acquire just a single nephropylographic phase at 90 to 100 seconds after the second injection. The second was the virtual non-enhanced CT, in which you can post-process the entire CT urographic material from a contrast material enhanced study acquired with a dual energy CT scanner. Now, there have been some techniques also which have been described to optimize distension or opacification of the pelvic calyceal system and ureter. And most of you are familiar with this, the use of diuretics, such as furosemide, which is administered 1 to 3 minutes prior to the contrast material injection, and infusion of saline as well as oral hydration. Now, as far as detection of renal calculi go, there are various modalities which have always been available to us, such as plating films, ultrasound, non-contrast CT, and MRU. But with the advent of low-dose CT, all the other modalities have been obviated. Now, we carry out low-dose CTs in which the radiation exposure is up to the level of less than 3.5 millisieverts, and even the ultra-low dose CT, which is up to about 1.9 millisieverts. And these are good for detecting almost all calculi. Let me show you some examples. Now, this is a renal calculus, which we can see in which the information that we can give is obviously the location of the calculus, the size of the calculus, and most important, the density of the calculus, because that leads us to the etiology. Again, another example of a renal calculus, which is seen on a plain scan, and on the contrast scan, you can see that it's obstructing the calyx and causing focal calyectasis in this region. A mid-ureteric calculus. Again, the advantage is that not only are we able to visualize the calculus, but we are able to visualize the proximal effect that the calculus has, the amount of hydronephrosis, and any other complications that the calculus might be causing. a calculus in the pelvic junction with some amount of urothelial thickening that you can see in the pelvis and the calysis. So you know there is some amount of secondary obstructive changes which are going on in here. Again, another calculus are the vesico-ureteric junctions. So as I can demonstrate in the entire urinary tract for visualization of calculi, as well as for visualization of its effects, intravenous sonography is the modality of choice. Now let us learn a little bit about the renal vascular and tubular anatomy, because this will help us to understand how CT urography helps and how we can optimize our technique to better detect lesions. Now, as you can see, this is the renal cortex and this is the renal medulla. The renal cortex has a rich vascular supply, which is lined with glomeruli, which is a lobulated collection of convoluted capillary blood vessels, and peritubular capillary plexus, which is again a capillary network surrounding the renal tubules. So basically it has rich vascular supply. Whereas the renal medulla, it has the vasa recta, which is a capillary plexus which is descending into the medulla, which is quite dense in the proximal medulla, but it is less dense and contains fewer vessels as we go in the inner medulla, tapering towards the papillary tip. The important point to note is that the papillary tip receives only marginal blood supply, and therefore the tip of the papilla are very vulnerable to ischemic necrosis or papillary necrosis. Now, this is what happens on a normal renal enhancement on the CT scan. This is what happens histologically once the contrast is injected. So in the first corticomedullary phase, you can see that there is intense cortical enhancement due to the glomeruli. What we've seen, which are the collections of capillary blood vessels and the peritubular capillaries. The medulla does not enhance that much in the initial phases. Okay, but in the nephrographic phase, you can see that there is slower enhancement of the medulla as compared to the corticomedullary phase. And this is because the contrast in the vasa recta and the filtrated contrast in the renal tubules has reached the medulla. In the excretory phase, this concentrated contrast is seen in the papillae and it's seen in the renal collecting system. Now, there are different types of anatomies that we can see of the renal collecting symptom. Now, either you can get multiple papillae which empty into a single calyx. This usually happens in the upper pole, which in this case, it's called as a compound calyx, or you get a single papilla which empties into a single calyx. This often happens in the mid pole, which is called as a simple calyx. Each of these minor calyces, whether they are a simple calyx or a compound calyx, unite with their neighbors to form a major calyx. And these major calyces then finally unite to form the renal pelvis. Now, some anatomical variations, anatomical appearances that we must really look out for. Now, this is an excretory phase axial image. It shows a prominent normal papilla, which may stimulate a polypoid mass. It should not be mistaken for a urothelial lesion. You need to see it in different orthogonal planes. This is an oblique sagittal image, and you can confirm that this is a normal papilla by its central location and by the fact that it has a very smooth contour. Now, the normal papillary brush. Okay, so these are early excretory phase axial CT images. This is a soft tissue window, whereas this is a wide window. This axial and coronal wide windows, they show indistinct, very prominent papillary opacity in a blush-like appearance. This represents the normal concentration of contrast in the medulla. Okay, this normal papillary blush we see is accentuated with the now used low osmolality contrast media. This generally happens because there is less fluid which is excreted into the tubular lumen. Therefore, the concentration of contrast material is much higher than with HOCMs. Okay, this is a normal appearance that we must look out for. Now, coming to a condition called as benign tubular ectasia, it's a condition characterized by dilatation of the renal collecting ducts in the papillae. So, benign tubular ectasia is an isolated finding of linear contrast collections, whereas medullary sponge kidneys contrast collections associated with urolithiasis or medullary cancerosis. Some of the authors generally consider both these two as a single entity. Now, they're generally characterized by paintbrush-like appearances, which can be multiple, discrete, linear densities, which are usually seen in the pyramid. This should not be confused with the indistinct normal papillary blush that we've seen previously due to the normal concentration of contrast. Now, usually this benign tubular ectasia may be associated with stone disease, may present as hematuria. It can involve only one, it can involve few, or it can involve all of the chalices. It's seen bilaterally in 60 to 80% of these cases. So in this case, you can see this is a 55-year-old man who presented with microscopic hematuria. These are excretory phase axial images. Again, this is a soft tissue window. I'm showing you different windows again and again to tell you that how by changing the window width, you can pick up subtle lesions more easily. So this is a soft tissue window and this is a wide window, whereas this is a coronal MIP image. These in the soft tissue window, you cannot appreciate the paintbrush-like collection of contrast, whereas in the wide window and the MIP images, you can clearly see that there are linear paintbrush-like collections of contrast in the dilated collecting ducts. Okay. A medullary sponge kidney is an idiopathic dilatation of collecting ducts, resulting in urinary stasis and stone formation. It's associated with a number of conditions such as hemihypertrophy, Ehlers-Danlos syndrome, Beckwith-Wiedemann syndrome, and Caroli's disease. Now, this is a case of a 48-year-old man with history of urinary tract infection and gross hematuria. This is a plain CT scan. It's a coronal MIP image. It shows extensive calcifications which are seen bilaterally in the medulla. Now, this is an excretory phase coronal MIP image. It shows calcifications in the dilated collecting ducts that you can see out here, as well as additional densities which are there. These additional densities are because of contrast accumulation in the dilated, cystically dilated ducts, which are not containing any calculi within them. Now, in many patients, this is another case which is showing a non-contrast axial CT image showing medullary calcinosis in bilateral kidneys. Now, on the excretory phase CT in soft tissue window, these calcifications and the dilatation of the collecting ducts is completely obscured. You can't make these out. Whereas if you change the window, you can see that the calcifications are located in the dilated collecting ducts. And also you can see that there are cystically dilated ducts which are there, which are separate from the calcification. Coming to medullary nephrocalcinosis. This is a deposition of calcium salts in the medulla, which can be either in the interstitium or in the tubules. The common causes are hyperparathyroidism, which is the most common cause in adults, medullary sponge kidney, renal tubular acidosis type 1, and some other conditions which cause hypercalcemia or hypercalciuritis. Most of the entities that cause nephrocalcinosis can simultaneously cause urolithiasis, that is stones within the urinary tract. Now, this is a case of a 40-year-old male who had got a prior, whose parathyroid carcinoma was resected earlier. He presented with lung metastasis and recurrent hyperparathyroidism. This is a lung window setting which is showing a nodular lesion within the parenchyma. These are axial and coronal non-contrast images which show multiple calcifications, tiny calcifications in the medulla, suggestive of medullary nephrocalcinosis. And these are changes of hyperparathyroidism with demineralization in the pelvic bones. Again, this is a 40-year-old man with renal tubular acidosis. He has a prior history of renal stones, recurrent urinary tract infections, and presented with right lumbar pain. You can see a non-contrast CT in the soft tissue window as well as in the wide window, and you can see a coronal post-contrast MIP image, which shows extensive, massive calcifications within the renal medulla. In addition, on this post-contrast image, you can see that there is a calculus filling the upper pole calyx. The scout image is also showing some amount of uretral calculi. So this is a case who had renal tubular acidosis type 1, in which generally when you see massive medullary nephrocalcinosis, the usual underlying cause is renal tubular acidosis type 1. Now, coming to papillary necrosis. The papillae, as I told you earlier, are vulnerable to ischemic necrosis. This is because the vasa recta, that is the vascular network which descends into the medulla, tapers as it goes towards the papillary tip, and therefore the tip of the papilla receives only marginal blood supply. The risk factors for papillary necrosis are like diabetes, analgesic abuse, use of high-dose non-steroidal anti-inflammatory drugs, sickle cell anemia, chronic infections. The way it progresses, the severity, it varies greatly. It may present with or without hematuria and decrease renal function. So there are various types of papillary necrosis that we can see. This is how a normal calyx and a papilla looks like. In the medullary type of papillary necrosis, you get central erosion of the papilla with a ball on tee appearance. So all of you who are golf enthusiasts will relate to this. This is how a golf ball looks on a tee before it is hit by the golfer. So this is a ball on tee appearance in which there is central erosion of the papilla. In the papillary types, okay, the entire papilla may become necrotic. Okay, in that you can get either erosion of one fornix, or if there is erosion of both the fornix, this gives you a lobster claw appearance. So we've got something for the avid golfers, we've got something for the foodies. This is a lobster claw appearance in which there is bilateral fornicial erosion. And if the necrotic papilla is retained in the calyx after sloughing, this is what we get. And the final stage is obviously calycial blunting and epithelialization. Now, this is a case of a 60-year-old woman with microscopic hematuria. She had a history of migraine using analgesics for a long period of time. And what you can see is these are again excretory phase images in soft tissue window. These are wide window images, and these are coronal MIP images. These are showing small extracalycial collections out here. If you can appreciate this, these are small extracalycial collections of contrast material in the region of the papilla. And this is the classical ball on tee appearance in which you can see that there is a collection of contrast here. So again, this is very difficult to appreciate on the soft tissue window, and you need to use all your window width and all your ability to format these images to pick up the pathology. Again, this is a case of a 46-year-old woman with history of multiple prior urinary tract infections. This is a coronal excretory phase image, which is showing evidence of a hypodense, marginally enhancing lesion suggestive of an abscess in the lower pole. These excretory phase images in the soft tissue window, wide window, and the coronal MIP images, they show dilated blunt, the upper pole calyx is dilated and blunted. And there are again multiple collections of contrast, as you can see, giving rise to a ball on tee appearance. Again, multiple ball on tee appearances. This is a case of a 28-year-old with sickle cell anemia, hematuria, and abdominal pain. And again, this is a corticomedullary phase axial and coronal images which are seen here in soft tissue window. You can see there is evidence of a filling defect in the blunted upper pole calyx. There's a filling defect out here, which you can see in this. In the axial and coronal volume rendered images, this filling defect is seen as the classical lobster claw appearance, which we have described earlier. Again, papillary necrosis occurring in tuberculosis. So 15 to 20% of tuberculous infections which occur outside the lungs affect the GU tract. These usually result from hematogenous seeding of bacilli in the glomeruli as well as in the peritubular capillary bed. The regional spread of this bacilli results into seeding into the renal pelvis, into the ureters, and the urinary bladder. Now, these are coronal nephrographic phase image, which shows thickening and blunting. There's thickening and blunting of the upper pole calyx with some amount of adjacent cortical scarring. This is an axial excretory phase image, which shows small contrast collection in the area of the papilla, indicating that there is some amount of papillary necrosis. Again, an excretory oblique phase sagittal image, so diffuse irregular wall thickening and enhancement of the left ureter and the bladder with long segment ureteral narrowing in this region. This is a proven case of tuberculosis. Coming to caliceal diverticuli, these are believed to be congenital abnormalities. It's usually a urine-filled urothelial line outpouching connected to the intrarenal collecting system, which can be anywhere from the renal pelvis to the calyx by a narrow isthmus. It's filled with contrast medium in the excretory phase if the isthmus is patent. Stone formation is seen in 1/3 of the cases, maybe single or a cluster of stones. Other complications which are related to caliceal diverticuli infection, rarely malignancies, rupture, xanthogranulomatous pyelonephritis, and renal abscesses. Now, the type 2 caliceal diverticuli, these usually emanate from the renal pelvis or the major calyx, tend to be larger, symptomatic, and centrally located compared to the type 1 communicating with either the minor calyx or the infundibulum. Again, you can see this is a caliceal diverticulum filled with. This is a plain scan. You can see the calculus in this case, and you can see that it is there is a diverticulum which is the isthmus which is opacified here. Again, this is a 20-year-old who presented with recurrent UTI. You can see this is a late corticomedullary phase axial and coronal images. They show a cystic lesion in the right kidney, which contains a calculus, which we can see here. The excretory phase axial and coronal MIP images, they show contrast accumulation within the cystic lesion out here surrounding the calculus. So this is a caliceal diverticulum with a calculus within it. Again, 53-year-old with a caliceal diverticulum, nephrographic phase axial and sagittal images, which are showing a small cystic lesion in the right kidney, which contains a small calculus. Okay, the excretory phase images and which are axial and sagittal images show contrast within the diverticulum as well as the narrow isthmus with which it is connecting to the calyx. The pharyngeal or caliceal rupture. The obstructing collecting system usually decompresses spontaneously by leakage of urine from one or more of the caliceal fornices. Now, this is because the caliceal fornix is the weakest point of the renal collecting system. Now, this extravasated contrast which is there, it may surround the renal pelvis or the proximal ureter on excretory phase echourography. The usual common causes include obstruction by distal ureteric stones or malignant extrinsic ureteric compression by nodes or masses in the pelvis. What happens is the patient symptoms improve abruptly because there is decompression in cases of acute renal colic. This usually has no clinical significance if the urine is not infected. But if the urine is infected, such as in pyonephrosis or xanthogranulomatous pyelonephritis, pharyngeal or caliceal rupture may result in extrarenal abscess formation. Now, this is a case of an 85-year-old who had colon cancer and pelvic metastasis resulting in right-sided hydronephrosis. You can see this is a late nephrographic phase axial CT, which shows right-sided hydronephrosis with decreased contrast enhancement of the right kidney as compared to that of the left kidney. Now, these are excretory images which are seen in axial, coronal, as well as sagittal planes, which show contrast leakage from the caliceal fornix, with the extravasated contrast which is seen surrounding the right renal pelvis and the proximal ureter. Again, this is a 56-year-old with a history of renal calculi and recurrent urinary tract infections, presented with urosepsis. Now, you can see these oblique coronal images as well as the sagittal images. They show this obstructing distal ureteral calculus with proximal hydroureteronephrosis. There is a pharyngeal rupture in this region with perinephric and abdominal wall abscesses. The ultrasound also is showing some layering and debris within it, which is suggestive of the presence of pus within it. This is a 40-year-old with HIV and UTI. The urine culture grew E. coli. Again, this is a coronal corticomedullary phase CT, which is showing diffuse wall thickening of the calyces as well as the pelvis, which represents pyelitis. There are some wedge-shaped hypodense lesions which I can see along the lower pole, which represent changes of acute pyelonephritis. In the arterial phase images, which we are seeing, you can see diffuse thickening of the ureters are also out here. This diffuse thickening of the ureters and the bladder with mucosal enhancement, which can be seen due to urethritis and cystitis. Now, coming to malignancies, now upper urinary tract urothelial neoplasm, they account for approximately 5% of all urothelium. But what is essential is that we need to assess the entire urothelium, because a lot of these are multicentric in nature. 2% of patients with bladder cancer have synchronous upper tract urothelial cancer. 6% of patients with bladder cancer have metachronous upper tract urothelial carcinoma. And 40% of patients with upper tract urothelial cancer have bladder cancer. So this is very important to assess. Whenever you see something which looks like a urothelial malignancy, it's important to assess the entire urinary tract in detail. Now, how does this urothelial neoplasm look like? It's usually a focal intraluminal mass, or you can just get urothelial wall thickening with some amount of luminal narrowing, or you can get an infiltrating mass. Usually these neoplasms enhance after IV contrast, which can help to differentiate from stone or clot formation. Now, this is a case of an 89-year-old woman who presented to the emergency room for gross painless hematuria. You can see axial and coronal corticomedullary phase images, which show a subtle enhancing mass in the lower pole calycial region. Okay. On the excretory phase images, you can see that this mass encases and narrows the lower pole calyx. On post-operative histopath, this revealed a high-grade urothelial carcinoma, which had invaded deeply into the renal cortex. Again, this is a 63-year-old man with previous history of bladder cancer. And what this demonstrates is multifocal areas of urothelial carcinomas. So you get axial corticomedullary phase images. They show very subtle soft tissue masses, which are seen in different calyces, in the upper pole calyx, in the low mid pole calyx. On the excretory phase images, you can see that these masses are impinging upon the calycial system. And this coronal MIP images can show you multiple filling defects, which are all urothelial carcinomas. So in summary, I'd like to say that low-dose CT is the modality of choice to evaluate calculi. CT urography may reveal papillary or calycial lesions such as papillary necrosis, medullary sponge kidney, renal tubular ectasia, calycial diverticuli, pyelitis, fornicial or calycial rupture, and urothelial neoplasm. And you must routinely change window, use wide window settings to view excretory phase CT, because only subtle lesions can only be detected in this kind of window settings. I thank all of you for a patient hearing. And this is a seminal paper which all of us had presented in 2015 with Dr. Fishman and Dr. Shilashek, which had won a Cum Laude Award. And most of the images are taken from this paper that we had written together. Thank you.
Great, Zubair. That was really wonderful. And we have 150 people still watching, and it's like midnight. So thank you for that lecture. And any questions? I think you have a couple of questions here.
Yeah.
And Prabhat Kumar is asking extrarenal pelvis versus hydronephrosis.
Extrarenal pelvis versus hydronephrosis.
Yeah.
So very easy to differentiate. You on any of the modalities, on ultrasound, on CT, or on the CT scan, generally on the excretory phase CT scan, if you see dilatation of the pelvis as well as dilatation of the calycis, you know it's hydronephrosis. Presence of the pelvis beyond the renal hilar margin, that should make you that should raise your this thing as an extrarenal pelvis. So you will get extrarenal pelvis also with hydronephrosis. So if you see the renal pelvis behind the hilar margin, that is extrarenal pelvis. In addition, if you see dilatation of the calycis also, so that is extrarenal pelvis with hydronephrosis.
Okay, there's another question: medullary sponge kidney versus medullary nephrocalcinosis.
So medullary nephrocalcinosis is one of the causes of medullary sponge kidney. Okay, medullary nephrocalcinosis, there are multiple causes. Obviously, there is hyperparathyroidism, renal tubular acidosis, and many other conditions which cause hypercalcemia and hypercalcidosis. And this is medullary nephrocalcinosis is definitely usually deposition of the calcium in the interstitium of the tubules. It has nothing to do with dilatation or dilatation of the collecting ducts. Whereas the medullary sponge kidney, it's a dilatation of the collecting ducts. It's an abnormality of the collecting ducts rather than of the depositing system. So medullary sponge kidney with dilatation of the collecting ducts, it may result in urinary stasis and stone formation, but the cause is completely different from medullary nephrocalcinosis.
Geeta Anand is asking, it's an extension of this tubular ectasia versus medullary sponge.
So that's a good question. Actually, that debate is still on whether to call this tubular ectasia or ectatically dilated ducts or this thing. I mean, Dr. Fishman says they are one and the same things, but the debate is still on.
All right. I think is it necessary to give the volume of the calculus? Priyanka is asking.
See, generally we tend to give it in all three dimensions. You need not calculate the volume of it, but it is ideal to give it in all three dimensions because with, first we had RRS and URSs and all, but now with the fine endoscopes that they put in, they really need to know in all the three dimensions what is the extent of the calculus. So ideally in all three dimensions is what you do. And it's very easy to do. It hardly takes 5 seconds to do. So it should not be any.
All right. I think we've ended the questions, and thank you very much, Zubair, for this.
Right.
And thank you everyone who's here watching until midnight. I hope you've had fun today with all the star speakers, including Dr. Fishman. And we'll be starting tomorrow, Sunday at around 9:30. We hope to end that session by around 2 o'clock to 2:30. And so we'll see you again tomorrow, and goodbye and good night.
Sanjeev.
Yes, Satin.
It's today only, not tomorrow.
All right. So I'll see you today later after a good night's rest. Yeah.
After a refreshing break, we'll see you again today.
All right. Okay. Bye-bye, everyone.
Bye-bye.
Good night. All right.